Thank you, Patrick. I'm going to start us off with the Karakia. I'm going to acknowledge the local iwi, those that have passed, and then I'll hand it over to Barry to officially welcome anybody. Mea noi tātou. Whakataka te hau ki te uru, whakataka te hau ki te tonga. Kia makinakina ki uta, kia mataratara ki tai. Kia hiaka an te atakura, he teo, he huka, he hauhu, te hei Māori ora. Te hau kāinga, Ngāti tō rangatira, taranaki whānau, tēnā koutou. Rātou kua wihi ki te pō, moi mai rā rātou, moi mai rā rātou. Rātou kia rātou, tātou kia tātou, tēnā koutou katoa. Over to you, Barry.
Barry, you're on mute.
Well, thanks, Peter, and welcome everyone to the fourth PHONZ Conference. We're delighted with the number of people that are registered and also the number of very distinguished presenters we have in this conference. On behalf of the committee, we welcome you all and hope you enjoy PHONZ25. I'm delighted to introduce our keynote speaker, somebody that I've known for a long time and has made an incredibly distinguished career already. Professor Bev Lawton from Victoria University in Wellington. She's also the founder and director of National Centre for Women's Health Research, and in fact has been and continues to be a pioneering force in women's health in Aotearoa. One of the many achievements of Bev's has been that she's led New Zealand's historic shift to HPV self-testing as the primary method for cervical screening and making Aotearoa the first high-income country to do so. In the course of her career, she's accumulated a large number of awards and distinctions, which includes the Bevan Medal by the Health Research Council in 2023. So I'm delighted to welcome you, Bev, and thank you for giving the opening keynote address.
Sure, thank you for that kind invitation and for inviting me. Ngā mihi, Peter, for that Karakia. So, ko waio tina koutou katoa, ko te ringi te munga, ko ua te awa, ko te atanga witi te iwi, ko Bev Lawton ahau. I'm delighted to be here, not least because I got my adrenaline surge getting through the traffic this morning. So, thank you for inviting me. Today I'm going to talk to you about our work in HPV cervical screening and your kind sort of introduction of leading. There was a cast of thousands involved in our new HPV cervical screening program. And as I called it, Tūāpapa Foundation Māori Foundation. So that's been really important to us. We should have practiced this. We'll just see if we can get those slides to go along. Hold on, we'll go up again. And down. Okay, just my decorations. None of them involve lots and lots of money, unfortunately. But we are funded by the Health Research Council of New Zealand and the Ministry of Health for these studies. Te Tātai Hora Ahine, which is our research centre. Just thought I'd tell you a little about us. Our vision is to eliminate preventable harm and death for women and children, and to reduce health disparities for Māori. We do Kaupapa Māori centred research, Kaupapa Māori research, and we want to create system transformation. We're strength-based, community-driven, community-owned, and I've written down whanangatanga. For those who are not aware of it, that is relationships. Excuse me, relationships are really key to our work, as is Māori research workforce. We affect our workforce, which means we embrace and support. Our work goes through an Indigenous lens. Whakawhanangatanga, relationships, kanoi ki te kanoi, face to face, the face that's seen in community. Manakitanga, for those who aren't aware, is to look after, to support, to give, to support and care, Tēnā rangatiratanga is a concept of self-determination. We have the right to determine our future, our actions, and our sovereignty. We use a high trust relationships in our research with the strengths-based approach. Our communities are vibrant and they want the best for themselves. And most importantly, we have leadership from our elders, our kaumātua, and we have tribal and iwi voice. This is really important to us and how we do our work, and we couldn't do it without it. So I'm going to focus my conversation on, as a case study on how we've been trying to address the elimination of cervical cancer in New Zealand. With the WHO call to action in 2018, this is the human papillomavirus, and for those of you who don't know and not clinical, this is not a very nice virus. It contributes to almost all cervical cancers. Persistence of this virus causes changes that cause cancer. It contributes to a large amount of throat and neck cancers and anal cancer. This is not a nice virus. And what's really interesting is when I went to med school, we didn't know that cervical cancer was caused by a virus, that anal cancer could be caused by a virus. And neither we know about throat cancer. So we didn't know about that. And now we know it's caused by a virus. And now we know that we can eliminate it. We can eliminate cervical cancer. And that's all in a lifetime. It's pretty exciting. It's just a job we have to do. So for those who aren't aware, cervical cancer is a cancer that affects the entrance part, the neck of the womb, which is there. And women do cervical screening. We're looking for changes on the cervix that may lead to cancer in the future. And so you can have pre-cancer, and that's exciting. If you're a researcher or a clinical person in public health, you can prevent this cancer by either eliminating the virus, not getting in the first place, or by finding the virus on the cervix and treating any changes that are there. So that's pretty exciting. So this is what I use and we use in our work. It's sort of a very simple graph. I'm sure it should be a lot more fancy. So you can take human papillomavirus disease down this, like you're looking for primary prevention. All those P are primary prevention. We are at least 4 places that we can address this dreadful disease. And the C stands for cancer. So we can be working and improving this pathway all the way along this disease continuum. Actually, I often suggest that we could actually not have, if you don't have sex, you won't get cervical cancer. And actually that, as a prime prevention, has not been the first on the list, I may say. So this is really very exciting because we're using innovation, and as things move along, we've now got HPV vaccination. We can prevent the virus that causes this disease, and we can screen for the virus on the cervix and we can do it ourselves. When formerly we had to have a very intrusive exam, now women can do their own tests. And not surprisingly, they really like doing their own tests. And I included this because even though we started to vaccinate everyone, all high-income countries started to do HPV vaccination about 2006, slightly earlier, on the evidence that the vaccine prevented or seemed to have less impact on CIN2, CIN3. These are the precursors, 1, 2, and 3 before cancer. So we knew that it seemed to prevent that. But we didn't know, because it's a long lead-in, that it prevented cancer. But the original trials were so convincing. And this trial here just shows that a real-world example of Scottish children, the first line of vaccination, who were vaccinated between 1988 and 1996. They were born between 1988 and 1996, and they were vaccinated when they were 12 or 13, and they've had no cases of cervical cancer compared to the group that weren't vaccinated. This is a very good vaccine. And as I say to our communities, this is a tonga. This is a treasure that we can give our children and our grandchildren. And not only will it prevent, we think it's going to prevent anal cancer caused by this virus. And this is one of the early ones coming out now, showing that people who've been vaccinated have lower rates of precancer in the anus. Now that's very exciting, and we're waiting for the results coming out on throat cancer. So this is really, really good news for us. We're getting a lot of bang for our buck for the vaccine. So unfortunately in New Zealand, our vaccination rates are very, very poor, and they've been falling. So we need to do an awful lot about getting our children vaccinated. We need to do a lot in this respect. Now, I wasn't going to stay on that very long, but I'd like to talk about our new screening program. So these are screening women who may in fact have changes on their cervix, and so we can prevent them developing cancer. And so we now know that looking for the virus is better than looking at the actual cells of the cervix. This is a screening test. So Aotearoa New Zealand commenced our primary screening program in September 2023. And it was the first high-income country to commence with self-testing. The women are doing their tests, looking for the HPV virus themselves. And they can do that at their primary care. And I put this on because for me as a researcher, and probably this is probably the essence of the talk, is that we're working as researchers and with other researchers in real-time communication before this program and developing this program. So we were doing the research, talking to the policymakers, the people who are making the actions, developing the program, and all the committees, they were acting on the evidence in real-time communication. The tribal groups, the community involved, were able to have a voice directly to the policymakers. That was pretty exciting. And because of that, we ended up with a completely different program from when we started out. And it's been a very exciting process. And we'll go through that because I think there's some key points here. So I'm going to give you some results which are confidential, please, of a randomized controlled trial we did in Te Tai Tokoro, which is in Northland. We asked, does a universal offer of HPV self-testing achieve non-inferior screening coverage or participation to a universal offer of cervical cytology, which is given with a speculum? So we say, why are we doing this? And wouldn't you expect that you offer our HPV self-testing? Perhaps women would like it more. And I'm sure all the women in the audience agree. But no one had done this. And if you have an organised screening program, you have an obligation, if you're going to change it, to actually make sure that you don't change it and get a worse result. Because we know that can happen. Because the Dutch changed their cervical screening program and they went from GP invite to central invite, and they dropped their screening coverage. So we needed to explore that. It was a question that wasn't answered. And we did that through quantitative, RCT, and qualitative. And I'm going to give you some of these results. And we had implementation practices, comparison practice, and the primary outcome was coverage. Usual care is cervical cytology with a speculum. That's an invasive examination. So these are the results that, not surprisingly, the odds ratio was 1.68. They were 1.68 times more likely to have a cervical screen if they were in a practice that offered a universal offer HPV self-testing. So not only was it non-inferior, it was superior. So we have proven it. So it's not surprising, but we've done it. And in fact, we did quite a lot of qualitative work. Women were doing this because they're doing it not only for themselves, they were doing it for their whānau or their family. And as you can see, there's a diagram there. Some of the things we learned, we had a steering committee. We took all the tools to the steering committee. They threw out our first poster and they did their own poster to suit their community. And flipping the narrative was the term that we used, because we had a lot of women were telling us that, especially younger women, that their aunties and their nanas were saying, you've got to go and do this thing, the smear, and you've really got to go and do it. But it's invasive, it's uncomfortable. But you still got to do it. So not surprisingly, they didn't do it. So when they got to be offered a self-test and they just did a swab and they could do it themselves, it completely flipped the narrative, and they took control of it. and it empowered the community. So they went out on social media, they got their aunties, they got the nanas, they got everyone to come in and do the test. That was pretty exciting. So what happened then? We stopped our trial the day before the program started. And this is some of the preliminary data from the National Cervical Screening Program using HPV testing. So we've had over 645,000 tests up until the end of April. But what's really interesting is about 18% since the rollout were on under or never screened. 82%, 82% of women are choosing to do an HPV self-test rather than the more intrusive test. So that's pretty exciting. So there again is the coverage report, and that's the up-to-date. And you can see from the end here that it's the peak that's gone up. Generally, screening has been going down in New Zealand, as it has been globally, in different ethnic groups. And since we had the new program, you can see the uptick here. That's really important. And some groups are reaching other groups, which is non-Maori, non-Pacific, and non-Asian, have reached well over the 80% target. So that's pretty exciting. So again, that proves what we tried on the trial. So in reality, it's working. And this is the 5-year coverage, which is really impressive. So what have I got here? I've got a slide here, and I'm going to leave the slide here. I've been presenting the slide. I've said to the ministry, I've said to them, why can't we present the results? And I think this is a worldwide thing. If you've been involved in your nurses, your doctors, your communities involved in a screening program, generally what we're seeing is coverage. We're saying, oh, we've done 50% done bowel screening or breast screening, but no one's actually telling us what we're finding. And if we deal in outcomes as conditions. So if we said that over the last year, that there was, you know, we found this many cancers, we found this many pre-cancers, you're doing a great job. Wouldn't that make a lot better sense in the loop of screening programs? So it's still empty. I am allowed to say, even though I know the results, they said to me, I'm allowed to say that the results to date are what we would expect. So that's what we're allowed to say. So hopefully we can fill that up in the future. We're still going through all sorts of connections so that we can actually give those results back to our clinics. We don't want to know which area they're from. We just want to know that New Zealand's doing a good job. So why did it work? Why was it successful? I mean, it used innovation. It used HPV self-testing. It used it used a new test. It used HPV. So we were able to have a lot of training. And this is where it's sort of the kaupapa is Tūāpapa. The foundation is Māori. We based it on our research, which was based and geared towards Māori. It wasn't other. Normally we're other. So normally to explain it a bit more, a lot of our programs are based on systems that come from central government, that are based on often colonial concepts, not even based on anything from the community. And Māori are often othered. Oh, we'll just do it like this and we'll catch up later on the other group, whoever they might be. And whichever country you're in, you're doing the same thing. So you need to change your foundation, your Tūāpapa.
Bev, can I just interrupt for a moment? Can you share your screen?
Have I not shared it?
No.
Oh, look, you should have said something. I've got great slides.
Yeah.
We shared it before. Hold on, let's see.
Yeah.
He must have taken it off before.
Yep.
Oh dear, that's embarrassing. You'll all forgive me. Hold on, let me see. That one, is that working?
Not yet.
How's that?
There we go.
So
Maybe-
what we do, now I'm
Maybe-
just before you didn't tell me that, hold on, did you text me? Never
Yeah.
mind. What we're gonna say is, I know what it did, it's when you went back, Patrick, into something else, because I was sharing it before. Okay, let's go back. That's not going backwards and forwards. Why isn't that? How about that? Ah, now we've gone into my mouse. Let's go back. Okay. How about that? Aha. Now, why don't I just start with this one? This is the results of our, can you see that, everyone?
Yep.
Well, look, this is great. Next time yell, Barry. I'm good when you yell. Now, everyone can hear me, everyone can see. You've missed the best slides. The best slides are showing that this has been a fantastic implementation of this program. And I think that's, I've got here, I want you to see how it's gone up at the end. And I sort of want to emphasize this because we have introduced a program based on Tūāpapa Māori, based on Māori sort of ways of doing, ways of communicating, and we've had this incredible, I don't know, I shouldn't say permission, we've had acknowledged that the ministry has been involved in this and listened to the community to input to get a good program. But I'm sure that what we're saying, what you're seeing, my point here, is that we've done this new program and we haven't hurt other people. We haven't hurt the white fellas, the white privilege. They haven't gone down by us basing a program on Tūāpapa Māori. And in fact, they have gone up. The other group has gone up with their screening quite markedly. And for Māori, they've gone up. So this has been a success. And I think this is the point we need to make, is that if we do our new programs and we base them on something that really matters, our community voice, it makes a huge difference and it doesn't disadvantage other groups. Because quite often in a community, there's a major group that feels disadvantaged if you swivel the focus on a program to another group. So this has been really successful. And I'm also going to, can you see that slide? Just making sure. But anyway, this is one of the other studies we've done, He Tapita Whao Tangata, Empowering Rural Solutions on Wairau on the East Coast of New Zealand. So this involved 6 research sites and 6 remote rural clinics. And we did a mixed methods Kaupapa Māori study, a cluster randomized crossover trial. And this was about the clinical pathway. If you had community control of a pathway from beginning to end, what would that look like and how would the community like it? So in every wahine in this case every woman was offered an HPV self-test. And the question here was, does a community controlled cervical screening pathway paired with point of care technology lead to a timelier colposcopy? And so what we did here, we had 2 pathways. The first pathway, hopefully you can see there, nod Barry, you can see that? Good. We had the point of care test results in an hour, and you can actually do the PCR test. I love the fact that because of COVID, we all know what a PCR test is. But this gene expert gives you that result. So we knew if they had HPV from the self-test within 1 hour. The immediate on-site result to the patient with information and support, and then we refer to the next step, which is colposcopy, to get a diagnosis. And then the clinic could ring up and make the appointment. So normally you get the test and the swab goes off-site to a lab. It could be a week before you got it back again. And in fact, during our study, swabs got lost somehow in the courier. So they went off to the lab, the results came back to the nurse, the patient was notified, and then there's a letter to the gynecologist to get an appointment, and then colposcopy was made. So what would happen if you inserted some technology, you got control of the pathway in the community? We asked the question, everyone was offered a test, point of care, results in an hour. One group were just doing the test and sending to the lab. So a crossover trial. And it was really interesting because it was in February, to crossover trial, and it finished in 2023. And those pictures show you that this was able to be done through COVID, able to be done through a cyclone, because you can still do the test in your centre, medical centre, even if the bridges weren't there. So again, there's some unpublished data. I don't want you to copy or distribute at this stage. We're under review. So in the study participation here, as you can see, we recruited, these are the recruitment numbers for the wahine or woman that were recruited, period 1 and period 2, and there was a crossover. As you can see, one group had point of care and one had usual care, which was a swab to the lab. And these are the results that are negative. With HPV, you expect about 90% to be negative and 10% to be positive. Here it was a bit lower, but these are the results we found. Very few invalids. So these are the periods of colposcopy. The colposcopy is needed to actually see what the diagnosis is. The screening is the HPV test. The colposcopy is the diagnosis. And there's no point in seeing screening people if you can't get them to colposcopy. And as you can see, we have high rates of getting to colposcopy. And as you can see, there were CIN2, 3, again, good saves, good saves. Just go through there, 18%. That's quite high. So the primary outcome analysis was time to colposcopy. Could we get these women to colposcopy quicker by having a community-controlled pathway? And yes, that's no surprise. The outcome was less than 20 working days from the test to colposcopy. It was 4.23 times more likely to attend within that time. It is very successful if you let the community take control. Interesting enough, for women, you'd expect them, we expect them to wait around. Of course, they're not going to wait around for an hour for a test. So they go shopping or they do this, do that. But then the nurse was able to ring them and they were able to inform them again within a short period of time that their test was positive or negative. So it answers the question and it supports a community-controlled cervical screening pathway paired with point-of-care technology. So again, the key points, I think we've discussed some, is really important. The Tūāpapa Māori, community strength-based, community-controlled, community solutions with a whānau family voice. And I'd like to put this here, I think facilitators. We shouldn't think barriers, we should think how to overcome them. We need to integrate across the HPV spectrum, disease spectrum. And really, innovation's making quite a difference to our world impact. So when is our goal for elimination in this country? It's 2035 in Australia. For UK, it's 2040. We don't have a goal because we don't have a plan or a strategy in New Zealand. So I've suggested 2037 to the minister. I think if all of you keep saying the same thing, we may get an elimination strategy. So what is our challenge? We need to go for elimination. How many things can we eliminate? How many cancers can we eliminate? We need everyone on the waka or the boat. We need action, we need government buy-in, and we need a joined up approach getting across the table. I just thought I'd put this in, because sometimes we're talking about diseases and we don't realise that, in fact, the average age, these are real whānau, real families. The average age for cervical cancer in New Zealand is 41. And this is a Taylor Morrison, who was 42 when she died of cervical cancer. She said, her whānau said they weren't offered everything. They just want to be asked and offered everything that they can have and not make any judgments of whether they can afford or not. And so she started Smearing and Mayor to encourage others to do screening. A wonderful, wonderful woman, a wonderful whānau. And again, contributed to us taking control of cervical screening. And this is what her mum said. She wrote this whakatauki for her, a proverb for her, and why must we get the job done of elimination? And I thought I'd share that with you because it's really important. In English, it says, why? For the health of women, for genealogy, for continuity, for our children and our grandchildren. Because we're really families, they're real people who get cancer. And she said, at that stage, she gave me the slide. She said, there were 13 of her whānau, 13 tamariki or children who will grow up not knowing their auntie. So this is a really real impact disease and we need to get rid of it. So we're not need, as we said, we need free cervical screening, we need leadership and targets. But I'm going to bring this back again to you as your public health forum. That I think we need to talk about things being a continuum and not just one part of it. And we need to use this for many things. Again, it's a disease continuum. I put this in as the new slide for me. I've been trying continuously, why aren't we getting the people who are organising cervical screening sitting next to the people who are organising HPV and immunisation? Why aren't they all in the room together talking? And I put them side by side because they're a bit like teenagers, and that's how you're supposed to talk to teenagers. Put them in the front, and that's how you get solutions. So these are opportunities. This is one of my favourite slides. I'm just special share it with you. This is one of the things that Chaim and Jada actually made me realise that, because when you try to address equity, it's a bit depressing. Well, how can you do it? Our change is actually going to happen. And this is a great paper, actually, dental care in the military. And it shows that if you're in the military, you end up with exactly the same sort of dental, decayed teeth taking out. And they don't have any differential between Black Americans and white Americans in the military. Because guess what? Although they might come in with different dental outcomes, they have exactly the same dental treatment. It's compulsory for them to actually go to the dentist. They have exactly the same treatments for exactly the same hole, and they get driven there, and they have protocols, and it's free. And guess what? It works. I think a bit of compulsion would be helpful. And another slide there. You can change behaviours. The whole world is now walking with new technology in their hands. So we can do this. We can do anything we want, really. So I just put that in because there's a lot of new technology we're going to insert into our clinical care pathways. But don't forget that it's only an insertion. It's still a continuum, and we shouldn't. It's just some of our tools that we can use. And we can get it wrong. See, there's new technology. Vaping, we got that horribly wrong. We should never have let that go into any continuum in this country. And I applaud the countries that didn't let it in. So how do we achieve our vision? With persistence. With facilitators, not barriers, casts of thousands. We always get the best to work on our trials, and we have to be accountable to our community, accountable to our research, but most of all to our community. I put AI in there because someone today is surely going to tell us that it's going to impact on all we do. And again, it's a blank slide. I'm a bit scared to fill it up. This is my Tūāpapa Māori wish list. Bloodborne pathogens, uterine cancer, congenital syphilis, which should never happen in this country, and maternity. I think we need to take our little chairs, sit together, and do some new programs. We throw the old ones out, they're failing, and do it Tūāpapa Māori. So again, research activism, this is what we need to do. We need to get the evidence, and we need to lobby. And if we get it right for Māori, we get it right for everyone. And I think that's what we need to look at in our countries. We need to look at where we should shift our programs, where we should redevelop them. Because you'll look and you'll find your programs that have been there for years aren't working for your people. So I shall end on that slide. I gave you half my slides. So kia ora, any questions? Barry, do you want me to go back to the beginning slides?
Since Barry's on mute, I'll step in there. I think we can move into Q&A now. Hopefully we should have an excellent battery of questions lined up for you. So if anyone does have any questions they would like to ask Bev, you can either put them into our Q&A menu, which will be down the bottom of your screen somewhere, or you can raise your hand and I will unmute you and let you ask your questions directly.
Bev, Barry, I have a question. So you've got lots of vision, and I mean, it's a wonderful presentation and your enthusiasm is very evident in it. What's the key obstacles to achieving what you want?
I think it's a really good question. I mean, you saw our diagram of working with government, working with ministry, and working with the iwi community. I think that's might be an obstacle. It's a willingness to do it, and that was so exciting. So I think that if we do more of that, and money, it's always funding. Because what we're going to do, we're trying to change systems. And you know what? Systems do not want to change. Systems support themselves. They've got we've done it this way forever. We've got a job doing this. We don't want to change. And we've got a lot of battles trying to change anything. So systems, they've got the self-defensive mechanisms built in.
So if you had a magic wand, what would you do?
What would I do? Oh, I'd address, I think, uterine cancer, and congenital syphilis, bloodborne pathogens. I'm sure there's someone who likes bloodborne pathogens. Can't drop syphilis, and half the people these days don't know what that is. But yes, what would I do? I'd set up a centre that, like I've got, but actually have it in perpetuity, actually having responsibility for those streams, and just get every one of them done, and just make that happen. I mean, I've got my issues, but it's the way of doing things. And if you're not looking and listening to the community, then we're not getting the programs right. And it's not only is it personally not effective with the burden, it's not cost effective. Yeah, I would like 20 million, by the way, Barry.
Any other questions? So a number of people have already commented, Bev, great presentation. So again, thank you.
Didn't see the slides.
So are the politicians on side? I guess that's the key thing. Are they, I mean, at the end of the day, the politicians and the policymakers are the people you got to persuade.
And I don't know why it's so hard. And I would like someone to answer this question. Is it because it's women's business? Don't know. But Australia started their HPV program in 2017. We started in 2023, and we still haven't got an elimination strategy. Why is it so hard? It's not, and it took a lot of work by a lot of people to get that budget, to get 2023 started. So it wasn't a lot of money. So I don't know why. I think that we need to get all of them on side.
It's odd, isn't it, in a time of targets, you would think that New Zealand would have a target. I mean, we have an environment at the moment, targets for everything.
It's low-hanging fruit, this, because you've got two things you can attack it with. You've got a target, less than 4 per 100,000. And we could really get there. We could really get there. Shall I stop sharing?
Yes. Okay.
Yeah, there we are then.
There's a question here. Your study reduced the burden. Your study reduced burden on clinical symptoms or hospitalizations.
Ooh, that's a good question. The study was about screening. So what we're doing is screening to prevent cervical cancer. Now, if a woman goes to have a screen and she's got symptoms, she's not screening. She's having a diagnostic and she goes down a different clinical care pathway. We would have, by catching cervical cancer early and preventing it, then we obviously will prevent that downward consequence of having cervical cancer therapies, hospitalizations, and death. But, 41, that's a young age to be taken out of the family.
Anybody else got any questions for Bev? We will get the rest of your presentation online.
It was going before when I started, before that. Never mind, we managed it anyway. And thank you all for listening. And I hope you're all going to sort of think about your programs and try about changing the Tūāpapa, the foundation, because I think that's the secret.
Yes. Is there any other advice that you'd offer people in the policy or whatever area on the basis of, I mean, one of the things is you picked off cervical cancer, but you've been involved in a wide range of women's health issues and over the years. So what's an obstacle to improving? I mean, we talk about equity, but, how can women's health generally be improved? What's the solution here, Bev?
Well, we've got a women's health strategy. My answer to that is we do not need strategies, we need action plans. I'm sick of another strategy that sits on the wall, or sits in the cupboard. We need action plans, we need issues, and we need to get the job done. But we can't get the job done if you men aren't willing to put your hand up and make it happen, because that's where the, oops, did I say that might be the barrier? I think, and there's lots of things we can make a difference, and particularly for women. I mean, it's, yeah, there's lots of, we need the lens to go that way. And it helps you guys too, because the women, you know, we're the centre, really, of the whānau.
And is that for all women, or, you know, Māori women have worse disparities in these areas?
Ah, now this is good. You're asking about disparities. I have done the whole presentation without a deficit slide, Barry. I'm not going to start doing one now. And I would be very surprised, Barry, if you didn't know about any disparities for Indigenous peoples. It's very hard when you try to do a strengths-based presentation. And so I suggest that people who just get up and do miles and miles of deficit slides with, you know, this person's lesson, they're very deficit and blaming. I think we should get up and put slides out showing the solutions. Because it's not acceptable that there are disparities. So we need solutions. And those solutions will help everyone, even those who have, you've seen me go, I'm going to have to say it, have white privilege. I did the whole presentation without saying that, do I? And I haven't mentioned the R word either, so I'm doing well. I didn't answer you, sorry, Mary.
Are there any other questions for Bev or comments that people would like to raise?
We do have one submitted from Erica, who asks, patients of Asian ethnicity did not appear to have rates increasing like other ethnic groups for screening. Do you have any ideas why this was?
So I couldn't hear that, sorry.
Oh, one more time, sorry. Patients of Asian ethnicity did not appear to have rates increasing like other ethnic groups for screening. Any ideas why this was?
No, but it's a matter of interest. I think it's quite interesting. So it is, it's really interesting. So I think that might be just another focus at some stage, and the numbers are small. So it is watch the space, and we are watching that space, so we don't have an answer.
Okay. Well, once again, Bev, thank you for a wonderful presentation, and your enthusiasm, and also best wishes for your next adventure, which I'm sure there are plenty of. But on behalf of all the PHONZ committee and also the people that are here, thank you very much for an excellent presentation.
Thank you very much. Thank you, everybody, for listening. Kia ora.
Kia ora.
Well, since we have a couple of minutes to go before our next presenter is due to start, I wonder if anyone objects to me doing a couple of quick bits of housekeeping. We haven't had a chance to plug, excuse me while I pull up the slide. We have not yet had a chance to plug our Mentimeter session for today. So for those who don't know, come on, progress through, sorry, PowerPoint issues. Let's try that again. So for those who haven't come across it before, Mentimeter is sort of an online interactive survey that will be running throughout the day with some questions for you to give your feedback on topics that are quite relevant to the topics we are going to be covering over the next few hours. And we're going to try and take your responses and feed them into our discussion sessions later in the day. So you can share your 2 cents worth, you can chip in to our running discussions by going to the link on the screen, www.menti.com, or scan that QR code, and then use the 8-digit code on screen to get you into the survey. And then you can fill it out in your own time. And as you fill it out, you will see not only your responses, but everyone else's responses as well for that on the screen. So that's a neat little thing that's going to be running through the day. And I will keep dropping this link in at intervals for you to be reminded of it, but we would love to see your thoughts and your responses to this. Right, back to you, Barry.
Thanks, Patrick. I'd encourage everybody to hook up to the Mentimeter. It's an invaluable way in which people can interact with the the whole program. So please do go there. I think we could start now with another speaker. And I think all the way from Trinity College in Dublin. And good morning, Paul. Oh, good evening.
Good evening. Thanks very much, Barry, for the introduction. So I will try and share screen and hopefully share my slides, and then I'll get rolling.
And just while you're doing that, Paul, I'll introduce Dr. Paul Kavanagh, who's the Interim Director of the National Health Intelligence Unit. And he's a medical doctor from Trinity College in Dublin. He previously worked in establishing Northern Ireland's Population Health Observatory, which is interesting, as we are the PHO in New Zealand. And the group that Paul is in is charged with providing epidemiological advice and public health support to health information system design, major national health service reform, population profiling, and health service planning. So, Paul, we're delighted that you've given up your evening to give a presentation today, and thank you very much.
That's great. Thanks very much, Barry. So, is my slides are showing okay?
Yes.
That's great. Okay. Well, look, I'm going to share some lessons learned and opportunities ahead in terms of how we might think about health information as a health system asset for the public good. And I'm going to share this from the perspective of our recent experience here in Ireland. So I'm going to start by being a little bit controversial and maybe a little bit pessimistic to begin with, and maybe pose the question, you know, if we look back to 1854 and of course the good work by John Snow in terms of arresting the transmission of cholera in London, and how he would have used paper and pencil, and he would have, you know, done some boot leather epidemiology at the time. You know, we're now in 2025 and we're talking about big data, digital, AI, so on and so forth. And I suppose, you know, the question for us to think about is over those last 175 years, has public health intelligence potentially actually got worse? So I'm going to start on a fairly pessimistic note, but hopefully move on from there. So what I'm going to do is talk a little bit about our recent experience in Ireland in terms of starting to think differently about health information and think about it more as a health system asset. And I think the story that I'm going to tell, Barry colleagues, is probably not that different to the sort of experience that you've had in New Zealand and in other parts of the world as well in terms of lessons from COVID. So a little bit about where we were here in Ireland. So this is the WHO framework that enables us to think critically about health systems. And as I would have been hoarse telling my colleagues here in the health system in Ireland, we do need to see health information and health information systems as one of the core building blocks of our health system, and start to use that in terms of trying to deliver our overall goals from a health system perspective. But that would have often fallen on deaf ears. And I'm sure you'd have similar experience in New Zealand in terms of trying to advocate around health information systems. We did a large scale reform of our health system almost 20 years ago here in Ireland. We're currently engaged in further reform at the moment. But one of the documents that would have underpinned that reform was Ireland's first health information strategy. So this document that I'm showing on the screen here is over 20 years old. And emerging from that, we would have made some fairly kind of piecemeal and probably quite fragmented progress around health information and health information systems. So we established a Health Information and Quality Authority, which had a remit in terms of setting standards around health information. We would have made quite piecemeal progress in terms of applying both geographic identifiers in terms of our air code here in Ireland, our postal codes, and then individual health identifiers to our different health information systems. We would have made very poor progress in terms of inclusion of equity stratifiers across our health information systems, and that's still a big challenge for us here in Ireland. In terms of yielding the benefits from electronic health records, again, progress there was very piecemeal with some quite fragmented systems which didn't speak to each other. And then I suppose from a cultural perspective, we here in Ireland would have implemented the general data protection regulations from the EU. We would have brought forward data protection regulations, and then further on from that, some health research regulations. And I suppose that legislative framework probably would have created a lot of ambiguity and a lot of conflict, and really not set up a culture in terms of maximizing the value of health information. And bringing all of this together then, I suppose I often tell people, if you think about it, you know, as a citizen using our health system, in fact, the citizen is an integrated source of health information. They have all the health information residing with them. But the way that we then set up our health system and then how our citizens navigate our health system, what we actually do there is we fragment that health information, and we disperse it across lots of different silos. And then what that ultimately means is that integrated information isn't available for citizens either at the point of care, when as individuals they access our health system, or for those of us that work in public health and we're thinking about this more from a health system or from a population health perspective, we don't maximize the value of that health information. So, you know, that's really the path that we would have been on over the last 20 years here in Ireland. So quite kind of a piecemeal and quite a fragmented approach in terms of thinking about health information and health as a health system asset. So what happened? Well, look, I mean, if you think about where we were 6 years ago, certainly myself, I would have struggled to place Wuhan on a map. But obviously at the end of 2019 and then into early 2020, we started to get to grips with a global pandemic caused by SARS-CoV-2. And I suppose through that experience, and I'm showing a picture here from, which would have featured every evening on our television screens here in Ireland. So this was our National Public Health Emergency Team, chaired by our Chief Medical Officer, who's at the centre of the table there. And then to his left-hand side, or on the right-hand side of the screen, is Professor Philip Nolan, who chaired our epidemiological modelling group. And each evening, they would have provided a press briefing that would have been broadcast on our national television. And I suppose that really brought home to us the powerful role that health information can play in terms of protecting the public health here from this pandemic issue in terms of SARS-CoV-2. And I often joke fairly badly that I'm sure it was a similar situation in New Zealand, but here in Ireland, all of our bars closed as part of the public health restrictions around SARS-CoV-2. But I think if our bars had been open and people would have been sitting on bar stools, the topic of conversation would have been the OR number and what the incidence was at that point in time. So we all became very fixated and obsessed and saw the value in terms of health information, in terms of managing that pandemic. And that was really critical then in terms of big, large-scale public health responses. Like, for example, we would have scaled up and done it at huge scale and huge pace, contact tracing here in Ireland, both kind of old-fashioned contact tracing down the phone, but we also deployed digital solutions as well. We would have used information from contact tracing then to project forward future scenarios. And then we would have learned in real time using our health information, both in terms of individual patient care, but also in terms of population care and how we might have prioritized the rollout of COVID vaccination here in Ireland. So I suppose, you know, going back to my initial thought there to start the talk around John Snow and, you know, the old epidemiological triad of person, place and time, and how that was so tried and tested, but maybe faded a little bit from our memory as we became a little bit maybe complacent in terms of moving into an era of big data and digital and AI. And really, you know, from our point of view within the unit that I lead, you know, we were back to some of the basics in terms of monitoring the evolution of SARS-CoV-2 across our population in terms of person, place and time, trying to use that data in innovative ways. I'm showing here, for example, at the top of the screen, some work that we've done around hospital early warning systems in terms of the potential for local incidents to potentially overwhelm the capacity of a particular hospital site, and we would have provided early warning around that. We would have done a lot of work in terms of mapping the evolution and the progress of the pandemic, and then we would have provided our colleagues who are managing outbreaks with real-time information at a very granular geographic level in terms of what was happening around COVID. We would have done research in real time as well. So I'm showing some research at the top right-hand corner of the screen here, which looked at the early experience in terms of COVID outcomes. I mean, nothing hugely innovative in terms of what would have been uncovered at the same time around the world, but we were able to really provide just-in-time epidemiological evidence in terms of, for example, the prioritization of COVID-19 vaccine rollout to high-risk groups, and then supporting public health messages in terms of shielding populations and high-risk groups. We would have subsequently as well done some epidemiological research looking at the differences in the evolution of COVID-19 here in Ireland across population groups, looking at the differences across socioeconomic groups in terms of affluence versus deprivation, and we would have tracked that as well and fed that information into real time. I suppose particularly where there was an awful lot of focus was trying to move beyond understanding what had happened in the last week or the last fortnight, moving beyond what was happening, understanding what was happening in real time, but actually trying to use that data to provide a more kind of predictive or forward-facing view in terms of what was coming towards us. So again, I showed the picture there of Professor Philip Nolan, who would have chaired the Irish Epidemiological Modelling Advisory Group, and they would have done a lot of work in terms of or numbers and then future scenarios in terms of what was coming down the track, what the different projected scenarios would have been in terms of the evolution of the pandemic. And then my own team would have done a lot of work then in terms of taking that very high level picture and then turning that into, in particular, projected scenarios around impact on critical care and impact on our hospital system, because we had very acute concerns within Ireland because of economic recession and under investment in continued expansion of our hospital system. We had real concerns which really drove our management of the pandemic around our health system becoming overwhelmed very quickly due to surges of COVID-19 activity. Then we took that a little bit forward in terms of a program of work that I now lead out on within our unit, which is around using discrete event simulation approaches and building a kind of a digital replica of our hospital system, and then using that to try and understand points of pressure and points of stress in response to demand that's coming towards the health system, in particular seasonal demand, as that may now relate to not just SARS-CoV-2, but also obviously seasonal influenza being back in parts of the picture in terms of winter pressures. So, what did we learn from it in terms of all of that, and where do we go next within the health system in Ireland? Well, around the time that COVID was unfolding back in 2021 and 2022, our good colleagues in our Health Information and Quality Authority, which, as I said, was established to set standards around health information, they used the opportunity of COVID-19 to really shine a spotlight on some of the gaps and weaknesses that there were within our health information and our health information systems here in Ireland, which I spoke to already in my earlier parts of the presentation. But as I said, when I made those points, they would have often fallen on deaf ears. But I think in the kind of heat of the moment around the COVID-19 pandemic, it was good to see our regulator in terms of health information take the lead and shine the spotlight on some of these historic deficits. Then at a government level, we would have seen an increased focus in terms of, for example, new strategic frameworks around digital, around data, and those in particular having a health focus as well. I think what was particularly helpful for us in Ireland is that in the background, there was an increasing focus on health information from an EU perspective and around building this idea of a European health data space and empowering individuals in terms of the use and the portability of their health data across member states. So really that would have lit a fire under our government and placed particular requirements in our government in terms of transposition and readiness in terms of implementation of that European health data space. And I suppose finally we're starting to see the government take leadership in terms of making sure that there is the right information in the right place at the right time in terms of ensuring that we have good clinical care for our patients, but as those of us in public health would know as well, making sure that that good data is reused in terms of population health as well. And then within our health services, there have been some developments. You know, for the first time within our health services, we now have sitting at the top table in terms of leadership, a chief data and analytics officer, which is something that we wouldn't have traditionally had. And again, I think that that crucible moment of COVID-19 really brought home those lessons in terms of the fragility, the weaknesses, the gaps in health information and health information systems. I'm pleased to see that we're starting to learn those lessons and apply that learning in terms of developing our health system. And of course then, and I've looked through the program already in terms of discussion over the next couple of days, you know, where does this bring us in terms of you know, the future, particularly thinking about now the potential that we have around big data. You know, within Ireland, we've looked at that already from a research perspective, and I suppose this is all around trying to reassociate at an individual level data that's across disparate health information systems and trying to really exploit that big data potential and the different technologies that go with that, like for example, machine learning and AI. So I mean, we've kind of taken a lead in that space ourselves within my own unit, and we have developed this strategic framework that we call the health support system, so that we are poised as we start to do the good work post-COVID to build health information, to build our health information systems, to really harness that potential in terms of this idea of a health support system and reassociating patient level information. This isn't just about data and technology, though. I think going back to John Snow and that analogy, I think we have to remember the art of public health practice. And I was interested in terms of listening into our previous speaker, who I think spoke to this very well. So I suppose it's about realizing that kind of issues that we're dealing with are complex and are difficult. And it's not just about the data and technology, it's about thinking of ourselves as practitioners in health intelligence and how we actually work on problems, work with stakeholders and navigate all of this complexity and use health information to try and make our health system better for our citizens. I mean, a good example here would be, we've for a long time had a lot of health information in Ireland that have underscored the burden that alcohol use places on our population here in Ireland. That would have culminated back in 2018 in terms of the crafting of a very strong and comprehensive Public Health Alcohol Act. But, you know, we have seen failure to launch in terms of that Public Health Alcohol Act. So in fact, you know, as we were recovering from COVID, we saw a new bill brought forward, which in fact, rather than trying to restrict and reduce access to alcohol, would have actually opened up access to alcohol. And I suppose disappointed to be with you this evening when news headlines today in Ireland are speaking to the fact that our government have made a decision to defer a commitment that there was in that 2018 Alcohol Act towards putting health labelling on alcohol products here in Ireland. And in the context of some of the issues that we have around tariffs at a global level and concern around impact on our economy here, our government have made this rather weak decision to defer this labelling implementation on the foot of all of that. So I suppose we all recognise that despite the best evidence, the best information, we can have failure to launch. And this is why we need to think about unpacking the black box and you know, the art of using health information, which all relates to these 5 T's here. So just in terms of wrapping up then in the last moment, I started on a fairly negative note, but I'll leave you on this more positive note. And I suppose I would hope through the story that I've shared with you in terms of our recent experience, particularly in that crucial moment with COVID here in Ireland, that, you know, we do have reasons to be optimistic. And I would say I'm not just optimistic, but I'm paraphrasing our famous poet Seamus Heaney here when I talk about being hopeful, because I think our recent experience here in Ireland has built our conviction that good health information, which is used well, is something which is well worth working from. So I'll leave you with that optimistic thought, and thank you for the opportunity to speak with you this evening. Thanks.
Thank you, Paul. Excellent presentation, and exactly on the topic that we were looking for. A couple of things before anybody has any questions. One of the areas that you highlighted is capacity and capability. And we have those issues in New Zealand, small country as well, limited capacity. So how is Ireland going to address those?
Yeah, so in terms of capacity and capability, Barry, and thinking particularly around capacity and capability in terms of public health and public health intelligence workforce. So in fact, over the course of COVID-19, we did, as many countries would have done, a large-scale review of our public health infrastructure. We've seen a big investment in terms of the public health workforce. We're looking at opportunities around multidisciplinary public health here in Ireland. And I think critically as well, in terms of some of those strategic documents around data and digital, we're looking at roles around data science, around statistics. We have professionalized those roles within our health services for the first time, created specific grades around epidemiology, around biostatistics, which we wouldn't have had in place before. So I think we have learned, Barry, that we really need to invest in capacity and capability, not just on the technical front in terms of the information systems, the standards, etc., but also on the professional front as well.
Thank you. Chris has got one. Congratulations on a great overview. Were you able to apply qualitative analysis during the pandemic to better understand how and why people reacted to public health guidance?
Yeah, so myself within the unit wouldn't have let out on qualitative research, but there certainly would have been that sort of research done. So in parallel to the Irish Epidemiological Modelling Advisory Group, which I referenced, there was a behavioural group established, and there would have been a number of people from a behavioural science and a behavioural economics background who would have done kind of mixed methods. So they would have done qualitative work, they would have done quantitative work, and that would have fed in terms of the design of our public health interventions. And the other thing that I would say on that front then as well is that we have just embarked on what we're calling here in Ireland a COVID evaluation. So we're not calling it an inquiry in that sort of kind of tribunal name shame sense, but we're calling it an evaluation. And a retired professor of nursing within our health system is leading that. So that is very much going to leverage some of those qualitative techniques to understand the lived experience and what we need to learn from that.
Thank you. Peter.
Thank you, Paul. This is a comment and a question. First of all, I found one of your opening slides very thought-provoking, and it was public intelligence is getting worse. I actually think public intelligence is getting better, but the difference between the public intelligence that's given and what's possible, I certainly think that is growing all the time.
It's fair. I think I was trying to be a little bit provocative early in the morning using the time with that comment, but I think there is something in it. And I think there's something around kind of making sure that we're doing our best in terms of leveraging all of the technical components of this. But as I touched on in my talk, I think we also need to be stepping back and thinking about the art of all of this, and not just, nothing I like better now than spending a little bit of time crafting or script. But that's fine in terms of giving you lovely visuals and lovely data tables. But we also have to be thinking about the art of how we use the public health intelligence as well.
One last question, David.
Kia ora, Paul. You mentioned the health support system, and I'm interested in your thoughts. What do you think is the most immediate and practical applications of AI in population health in the Irish setting?
Yeah, so we have a big challenge around population aging. Ireland, relative to other EU countries, we had a very young population for a long period of time. We are rapidly entering a period of population aging. We have some quite adverse behavioral risk factor profiles around obesity, for example. So we have a significant challenge around the emergence of chronic disease. we have very little visibility in terms of chronic disease, incidence, and then, you know, the natural history and the evolution of all of that at a population level. We do have some data sources. So we have hospitalization data, we have some GP data, we have some medicines data. And I think the health support system is around trying to reassociate that information and then trying to use emerging techniques like, for example, artificial intelligence, machine learning, to look at providing more sort of personalized, predictive, preemptive kind of approaches to chronic disease management. So I think that would certainly be, from our perspective, the kind of leading use case around those sort of technologies here in Ireland.
Thank you, Paul. We do have another question, and it'll be the last one. Do you have support from the political decision makers in your health system work in Ireland? Oh, that's a leading question for everybody.
Yeah, so I suppose, you know, if I was to pull out maybe a couple of the key messages from my talk there, I think for a long time when we were talking about investment in health information and health information systems, we didn't really have genuine support. You know, we did have a strategy document, as I say, 25 years ago, but very sort of fragmented, piecemeal, poor implementation of all of that. And, you know, I think the good thing is, through the experience of COVID, I think people have finally got this. And I think they are starting to see that in the same way as having imaging equipment, beds, good workforce, having good health information and good health information systems is critical in terms of the overall functioning of the health system. So definitely, I think in terms of political leadership around health information, we are seeing that in Ireland. And then, as I said, a very real manifestation of that, because now in our health services in Ireland, for the first time at the top table, sitting next to our chief people officer, our chief financial officer, we have a chief data and analytics officer within our health services in Ireland. So, you know, Peter kind of called me out on my kind of pessimistic note to begin with in my talk. But as you see, I did go 180 degrees and I did finish on a more optimistic note. So I would be optimistic, and I do think that there is kind of a little bit of a sea change and a real recognition post-COVID of the value of health information in the health system in Ireland.
Thank you, Paul. Thank you for a wonderful presentation. And we're fortunate that you gave up your evening to give us this. So we look forward to keeping in touch with you. And once again, thank you for an excellent presentation.
Thanks, Barry.
Well, moving on to our next speaker, I'm delighted to welcome Aaron Gorman to PHONZ25. Aaron is a data scientist at the Public Health Agency in Northern Ireland, so not far from Paul, and he's been working on modelling population risk factors and outcomes for non-communicable diseases. So welcome, Aaron. Welcome to PHONZ25, and we're looking forward to your presentation.
Thank you very much for the introduction, Barry, and thank you for the invitation. So really, really nice to be here. Okay, if I can just get someone to confirm you can see my screen, and there should be a set of slides present. Perfect. So good evening in New Zealand, everybody. Like I said, thank you very much. It's an absolute pleasure to be here. My name is Aaron Gorman. I'm a data scientist, so not only but epidemiological data scientist. I have a background in data engineering and data product design, and I'm here to showcase a strategic data product that we've designed that actually speaks to an awful lot of the strategic hurdles that our previous speaker alluded to around model and risk factors and non-communicable diseases, chronic diseases, consolidation of data sources to be able to really effectively model a population and that sort of thing. So I'm from Northern Ireland, as Barry mentioned. So it's one of the 4 constituent countries of the United Kingdom. A lot of our health policy is devolved, so we get to control it ourselves. We're very, very close to the Republic of Ireland, and I don't want to steal the previous speaker's thunder, but he did put up a quote from the Nobel Prize winning poet Seamus Heaney, who did live for a large portion of his time in Sandymount in Dublin, but he was born in Derry, Londonderry in Northern Ireland, like I said, don't steal too much of Paul's thunder. It was a fantastic talk, but just to note, we have our own Nobel Prize winning poet. So the data product. So what the data product does. So this is I'm from the Public Health Agency. It's a kind of arm's length body in the Northern Ireland public health ecosystem, slightly aside to the more political Department of Health. Its role is to oversee, its remit is to oversee public health communication and intervention, and both non-communicable disease monitoring, but also infectious disease monitoring as well. The remit of my talk will be on non-communicable disease modeling. Pardon me. Okay, so what is it? So I'm here to present the non-communicable disease forecasting and scenario planning and economic model. So that's a bit of a mouthful, but what it does do is speak to what essentially the core tenets of what we want something like this to do. So what we want something is something that really starts to consolidate data first and foremost. So after COVID, there was a big push for digitalization and to see a response in the data world to be able to meet the challenge of this epidemic that's overcoming us. It was very data driven. As you know, digital twins are very topical. A lot of things had to move online just because of a lack of human contact and lockdowns being put into effect. But also speaks to really digital transformation within health. And it wasn't driven by a want, it was driven by a need. It was a necessity at the time. So it did push the really software forward, digitally minded people to the forefront to start making decisions. And things were developed at pace, at speed. And it's good to see what can be put out given the need to do so. So we developed digital contract tracing solutions. We collected data on that, a backend database, and obviously developed out that analytics capability to be able to start to ingest that data and start to make sense of it. Otherwise, it's just a swamp, it's just a lake of data. This came out of the back of that. So obviously we're a little bit on from the COVID years, but that kind of mindset has stayed, thankfully. What we have is a kind of really rich data ecosystem now, and the capability set up to ingest it, to transform it, and to be able to understand it. So that speaks to multiple different data sources. It speaks to being able to consolidate and form a data model of those. And again, Paul alluded to this, not just having individual data sources, but being able to link them together is really, really important. It speaks to forecasting forward. So where are we going to be, not just now, but in a decade's time, a few decades' time? And that's going to be in response to risk factor trends. It's going to be in response to demographic shifts like bulges, demographic bulges like an aging population. And we want to be able to interact with that. We want to be able to see where we can interact and intervene on particular non-communicable diseases, given that their risk profile is such, and we have this ability to be able to devote resources to intervene on obesity or other modifiable risk factors. And then the economic component is that we want to be able to make this cost effective. At the end of the day, the Public Health Agency, much like a government and much like any public service, it should be in any way run like a business. So they want as much value back for every pound sterling, every currency spent. So what we're trying to be able to do is we're trying to put that in a robust framework, start to rationalize it, consolidate it, and then start to return value to the agency, to decision makers, to policy makers. And our tagline is that people are doing back of the envelope postcard calculations all the time. We should be putting a robust framework around this. We should be making it statistically sound and rigorous. So speaking to that, then we just we have a number of stakeholders that actually support us in this. So what I'm going to speak on, and I have some visual aids later on that'll explain this more completely, but it's a micro simulation. It's really high fidelity. We really try and model almost the individual risk linkage between risk and non-communicable disease output or outcome. So what we have is a clinical reference group to be able to engage with us. What we're trying to build is a high fidelity model of disease epidemiology. So a clinical reference group is important. We have collaboration with Queen's, a methodology reference group for more statistical robustness, and a central steering group for governance. And that's really, really important. So we want to be seen to be doing this safely. And any outputs are directed to the right people and interpreted correctly as well. So we want to be able to sell this. There's a little bit of a question on how do we get decision makers on side. It's incumbent on us to show value, and we want to be able to do that safely. So what do we model? We model non-communicable diseases across 4 core pillars of non-communicable disease, and you can start to see that they're already quite significant. Cardiovascular disease, you can break that down infinitely many. It's not just the brain and the heart, it's the kind of peripheral vascular system, kidney, diabetes. It's really extensive. Neurological disorders, obviously with an aging population, are extremely topical. Malignant neoplasms and cancers, screening interventions are seen to be really effective. So those are topical as well. And then chronic respiratory diseases are the smaller, less focused on cousin, but they're also important, and we've given them some attention. So that's what we try and model. What do we want out of it? So just to bring it back, it is a slightly more technical side, but this is the absolute most I'm going to tell you. It is high fidelity synthetic micro simulation representative of Northern Ireland. So what we've done there is we've taken census data, we've taken health survey data, we've taken GP data, we've taken hospital data, we've taken any data we can, and we've tried to mash it all together, for want of a better word. If you would like a better phrase, we'd consolidate it and build a data model around it. So we'd link it, we'd make sure everything's nice and neat and tidy, and put join keys across. So we know exactly in what region, with what risk factors, what age groups, what genders, everything like that. It's all consolidated. So the health system is very data rich, but it's extremely disorganized. What we try and do is consolidate and rationalize that. And that's really, really important. There's a fundamental step in discovery and consolidation that we needed to do before undertaking this. We want to produce a non-communicable disease model. So we want to be able to project forward non-communicable diseases, and we want to be able to intervene in those. So we want to be able to run scenarios whereby if we intervene on a particular risk factor that affects as an acknowledged risk of an outcome, we want to be able to say, if we knock this risk factor off, we reduce the prevalence, or we reduce the efficacy, or we modulate it somehow with some pharmaceutical intervention, some therapeutic intervention, some behavioral or dietary change. How will that affect outcomes? How much and when in time going forward will we see those effects? So there's a few more bullet points to just speak to the kind of discovery and the fundamentals that we need to build this. So it is quite a big project. There's a lot of discovery needed done. So as I think a lot of you will know, if you'll have touched data at some point in your careers, it can be mired in governance, red tape, it can be distributed, it can be siloed, and it can be dirty. Data quality is a very, very big issue. What we've had to do is build that kind of data model. I keep referring back to that. I used to be a data engineer. You always build that data model first, because then you know how everything links and you can visualize it. And then you can start to see what you can do. We do have some fundamental limitations whereby we don't quite have data to populate this risk factor or understand how that risk interacts with this outcome. That's what we did. We did that from gathering firstly Northern Irish data, but also then we hit the literature and we saw where is it reported elsewhere in the world. In particular, the risk linkage between a risk factor and an outcome was really, really good for this. They're well defined, they're acknowledged within population health statistics, and they're reported across across the literature. Across the world, really. We're very fortunate to be beside the United Kingdom, who has fantastic research on this, and because we share similar demographics with a lot of other United Kingdom countries like Scotland, Wales, and England, we can borrow an awful lot of their stuff. So that's what we want to try and do. But what returns value? Where's the cutting edge and where's the innovation in this? So for a couple of things, first of all, we've touched on this. It considers first and foremost the evolving population demographics of Northern Ireland. We get into a little bit of trouble with semantics because we sometimes refer to age and sex. Like I said, I'm a data scientist and not an epidemiologist or a public health consultant. So it's just a number to me. So I refer to age and sex as a risk. Not everybody agrees with that, but age and sex are risks in the sense that they modulate the risk profile of an individual depending on what state they occupy. And if a population demographic tends towards one risk profile than the other, that's important to be able to characterize. Bringing together complementary data sources for enhanced inference. There's more value in bringing together data than each individual data piece can provide. What I'm trying to say is the whole is greater than the sum of the parts. You really start to get a lot of value back when you start combining data sets, and that's the real difficulty here. Model high resolution risk. So it is a microsimulation, and what that literally means is we model down hypothetical individuals So we run a small population and then scale it up to Northern Ireland. The smaller population will have very similar risk profiles and demographic distributions to Northern Ireland. But what we can do in a microsimulation is arbitrarily like cut and split that how we want, look at particular targeted interventions to particular high-risk groups, be able to cut outputs like if we want by a particular age band, we model deprivation, we model geography, we model socioeconomic indicators, physiological risk factors, a wide range of attributes, to be honest. Pardon me. Being able to model down to that really, really high resolution, that granular resolution, means that we're building a really flexible model. And you're not fixed by model architecture, where if you set out to model an age band, by age band and gender, perhaps, of coronary heart disease, you're not fixed by the model architecture. It's extremely extensible, flexible, and modular, so you can decide what you want almost after you run the simulation. A quick point, it fills out some need for explicit multimorbidity. Multimorbidity is very hard to do. That's actually an old build point. We've actually got a really mature multimorbidity module that really starts to correlate risk factors together. People that have one risk factor, or smoke or drink, or sedentary, or don't have much physical activity, tend to have other risk factors. It's just the way of it's just how people's lifestyles kind of cluster together. We have a really, really good characterization of that. We'll touch on this later. We have a cost analysis and economic utility framework. Health inequality. Inequalities in health are a major, major theme in the Public Health Agency. So we're trying to see not just how much burden of disease there is in the population, but where is it? It's not distributed equally. And competing risk. So one of the innovations here is that we model all these non-communicable diseases together so that diseases interact. They don't directly interact, but for example, if you avert cardiovascular disease, you will see more cancer increases because you delay that onset of disease. Like I said, I refer to age as a risk factor, somewhat controversially, but risk is cumulative. So the older you get, you're more likely to have a cancer case just because you are getting older. We seek to characterize this. So literally at the individual level, I don't want to condescend, but this is as simple as it gets. We literally just try and mathematically have a risk factor such as obesity and see how it affects the outcome, such as coronary heart disease. And that'll literally be a number. It'll be a relative risk, and it'll just modulate the probability in our model of contracting or having a coronary heart disease, or it might be a myocardial infarction. And that's literally what we try and do. It's as simple as that, but it's repeated across the scale of what we try and do. So there'll be multiple risk factors for multiple diseases. Just a quick aside, what we try and do then is you start to see how the population statistics will never actually look at the individuals. They're hypothetical individuals. They're just there as a kind of statistical artifact. What we're going to look is the aggregate population data. So what you see is incidence, remission, and death at an individual level can be scaled up to incidence at population level. It's like almost like a group by count, remission as well, death as well. And then you can start to define things like prevalence. So change in prevalence would be incidence minus remission, minus remission, minus death. And this is just a small aside to say the same thing. What we sometimes do to get people's head around this is characterize it as a stock and flow model. So there's stocks and then there's flow between them. So there's a susceptible state. I don't mean to borrow terminology from infectious disease modeling, but susceptible or healthy state. You might have incidence that then moves you into a prevalent state. So you have that chronic disease. You can then transition back to healthy state through a remission pathway, or you can then die and then move into the death state. And then there's a constant balance and seesaw between these states, given that the flows in and out of the different states. If you want to know what how we've modeled that, it's a Markov chain model. So that's where the transition probabilities that we speak of at an individual level then get aggregated up to a population level. It's also important to note, once you have those transition probabilities, you have a kind of hook for intervention. So if you run an intervention, how is that mathematically represented? Well, we're going to interact with incidence and decrease it. We're going to increase remission, or we're going to decrease death. And then that this schematic just shows that as well. So you have prevention, pardon me, is where you move from the healthier state into the disease state. So you're almost like bottlenecking that flow. That's primary prevention. Remission, so you promote kind of convalescence, where it's a secondary prevention, and then you have tertiary prevention as well, which is mitigation. Diabetes would be an example where you don't really cure diabetes, but with effective treatment, you can live a long, healthy life. So this is an example of an intervention, extremely topical. This is in relation to the rollout of GLP-1 inhibitors. So our focus is on BMI change. It touches a lot of different things, such as diabetes, a number of other risk factors are changed, and it also improves the outcomes for an awful lot of disease incidences as well. We're focusing on BMI. So what we want to characterize here is actually twofold. So it's a little bit more difficult than usual intervention. We want to see how the GLP-1 inhibitors will affect BMI. So we want to define, moving from left to right, the population we intervene on. So it can be any arbitrary number of population group. So usually we'd go for high risk. We'd intervene on this, we'd see that mechanism and see by how much will that BMI change given that we've provided this intervention. And that'll include things like if it's a screening intervention, false positives, if it's an intervention for pharmaceuticals, there'll be a dropout rate, there'll be non-adherence, anything that the model there is handled by that intervention state. The BMI will change, and what that'll do is that will modulate the risk of morbidity outcome. The morbidity outcome will be across cancer, CVD, diabetes, like respiratory and neurological conditions there. So that'll modulate that risk. Hopefully it'll decrease it because we're on an intervention, but there's already a prevalence of interventions in the population. There's services out there. And if we take a service away, then there's no reason why that risk can't also increase. So it can go both ways. So it doesn't just go one way. Quick point here. This is a slide on the utility and economic model. So what we do then is we build this epidemiological kind of foundation. So we predict forward disease, we modulate that risk, we run interventions, and we kind of tune it how we want. We then want to, the public health agency is run as a business, it's got a finite budget, and it really needs to optimize that. It's largely a big optimization problem. They just want to get the best outcomes for the constraints, for the resource they have available to them. We've built ours such that it aligns with NICE guidelines. So the NICE is the National Institute for Health and Care Excellence. For interventions, it assigns a threshold of £20,000 to £30,000 per quality. I'm going to touch on qualities in a little minute. You might already be familiar. So it's really important that we align with that because that's what everybody's guidelines are going to be compared against. And that's what we want to be able to report back. So what we'll do then, we'll take our intervene state. We'll run a baseline state where there's no intervention, and we'll see here there's intervention costs from running an intervention. There's cost savings from averted morbidity and averted mortality. And from then, we'll calculate qualities. Qualities are the quality adjusted life years, so the equivalent healthy life year. And we'll combine these and we'll calculate an incremental cost effectiveness ratio. And that incremental cost effectiveness ratio is that threshold that's reported. It's a pound per quality. We can report that pound per quality, we simulate it, we calculate it, and that's the importance of running epidemiology alongside utility cost analysis and bringing them together. Compacts 3 dimensions into one, and then we can report back on interventions, check if they're cost effective against these NICE thresholds. So atrial fibrillation, for example, is a really topical one. It's not recommended for screening in the UK, but the clinicians are very much in support of it. We got a quality back of, an incremental cost effectiveness ratio of 10 grand per quality. The threshold's 20 to 30 grand, so we found it was cost effective. So we can do that before you run out and commit resources, or if it's a population-wide intervention that we can't really get a finger in the air feel for before you run it. We can use this tool to be able to demonstrate where we think that intervention is going to go and whether we should commit resource to it or assign that money elsewhere. And that's the end of it. Do I have 1 minute left?
Morning, Aaron. I'm just taking over the chairing responsibilities
problem.
from Barry this morning. So thank you very much for your presentation. It was pretty good. I think you were saying the right things for some of the issues that we're facing here. I do believe we are a bit over time. Is that right, Patrick?
It's not critically. We do have one question we can probably sneak in from Anya, who says, "Thank you for your presentation. Building a robust micro-simulation model takes a lot of skill and resource. What is the size of the team and the level of resource that has been committed to this work, and over what time period?"
Yeah, so like I think I mentioned it, it's incumbent on us to show value. So we got initial funding. More funding is contingent on us showing value. So it's been largely me building the model, and it's been incremental. So like I said, we built it. It's a software project first and foremost. We built the base model and then we made it extensible. So we're building modules as and when interventions come in, what we see relevant, and divert resource to what we think is going to return the most value. So it is extremely data hungry. I think there's a little bit of underestimation on our side about how much effort it really took to build this thing. But we got there in the end. We have a really good production model out, again, infinitely extensible to where it needs to go. I've been working on it for a year, but it's been largely cost effective. It's been only I can't quote you the spend that's been put on it, but we hope to start returning value within the next 6 months, and then broke even, so to speak, in terms of business value returned in 6 months after that. So that's 2 years from inception. Yeah, it is. I spoke a little bit about discovery. We should have done more discovery beforehand, but like I said, we onboarded skill sets, we onboarded data sets that we wouldn't otherwise have done. We have a new expertise that we can draw upon. So we think it's for the best, and a net benefit for the business. I keep referring to the business, but what I mean is the agency. Yeah, you're quite right though. It was a considerable undertaking, but one we're very proud of.
Yes, very much so. You've done well. Just for just yourself, I think you could easily have a team of many people doing that work, Aaron. So thank you very much for your presentation.
Yeah, thank you.
Great. I believe we're moving on to our next speaker this morning, who is Dr. Shaun Grannis. Shaun is the Vice President of the Data and Analytic Leaf Institute and the Medical of Informatics at Indiana University School of Medicine, and is a professor of family medicine at Indiana University School of Medicine. Evening, Shaun, welcome.
Thank you. It's good to be here. Can you see my slides okay?
Yep.
And I understand I have about 20 minutes to present. Is that correct?
Patrick?
Yes.
Yep.
Yep.
Yeah. Okay, great. Perfect. Well, it's great to be here with you. I am going to talk to you about the system and successes that we have had using real world data to support a number of public health activities using advanced analytics techniques. So the goal of this talk is to share with you what we think is an exceptional infrastructure that supports exceptional outcomes. So with that, we'll move on here. First of all, a little bit of geography here in the United States. I'm sure some of you may not know where Indiana is. There you go. We're just a little bit southeast of Chicago. So now you've got your landmarks for where we are, and I'm coming to you from right in the middle of the state of Indiana. I serve as the Vice President for Data and Analytics here at the Regenstrief Institute. I'm also a professor of family medicine and informatics at the IU School of Medicine. Regenstrief and Indiana University work closely together. The Regenstrief Institute has been a medical informatics leader for over 50 years now. Before Sam Regenstrief, you all put your dishes in the top of the dishwasher. After Sam Regenstrief, you put your dishes into the front of the dishwasher. Sam perfected the seal on the front loading dishwasher. What does that have to do with anything? Well, he had some medical issues, went to Indiana University Hospital, and after a couple of days there, he called the CEO down to his bedside and said, if I ran my business like you run this hospital, I'd be bankrupt. And so he saw the opportunity to begin investing in process engineering and technology in healthcare way back in 1969. And Regan Streif began recruiting physicians who are also computer scientists to begin to grow that out. Some of you might be familiar with the laboratory standard LOINC, maybe not. Regan Streif created that. So that came from Indianapolis, Indiana, and we maintain that standard. We're also authors on many other healthcare data standards as well. So we care about the data and the data standards because we know those are going to be the basis and foundation for better outcomes and being able to benefit by supporting multiple use cases down the line. So that's the Regan Streif Institute in Indiana in a nutshell. I've been the director of informatics there before becoming vice president, and we have a very large medical informatics group. So Regan Streif created something called the Indiana Network for Patient Care. It's one of the country's largest and longest running health information exchanges. We connect to nearly 20,000 clinical practices, over 54,000 providers. This just gives you a layout of where the providers that we connect to are. Part of the reason I'm giving you this infrastructure is after I talk about that, so you understand where this data is coming from, I'm then going to talk to you about how we use this to support AI-based public health interventions. We also have connections to 38 health systems, which amount to over 120 hospitals. We also have access to over 15 billion clinical observations going back multiple years. We have over 18 million patients. Because this has been running now for over a quarter century, we have quite a few people who come through the system. And so we've amassed a lot of data. This system has supported hundreds of research and public health projects. We capture from our health information exchange about 3 to 5 million new transactions daily. What does that mean? Well, a laboratory result, a new patient registration, a radiology image, a discharge summary, an EKG, all of those are a transaction. And we receive those from hospitals all over the Midwest region. And we accumulate 3 to 5 million a day. We've been doing that now we began backing up these transactions about 10 years ago. So we have over 4 billion of these transactions. This is big data. What is big data getting a lot of attention for these days? Training artificial intelligence. So this is one of our sources for training AI. I'm going back to this slide to remind us that we have connections to all of the hospitals in the country, or in the state, thinking New Zealand, in the state. Using those connections, we built out, I don't know if any of you remember after the US's 9/11, there were some anthrax scares, and on the heels of the anthrax scares, the federal government gave us funding to build out syndromic surveillance systems. And I don't have to explain what that is to this crowd. We built this out. It's now been running for over 20 years. We just had our 20-year celebration of our syndromic surveillance system. It's very rare for these types of systems to last that long, but we're excited for that. We collect data from all of these hospitals. Our first event that we detected back in December of 2003 came from Southwest Indiana. Our public health epidemiologist at the state said, hey, we see a peak here in our neurological event category. Called the 3 hospitals that contributed to that peak, and all of the emergency departments from which this data came, all of them said, we're not seeing anything unusual. Turns out that, as I mentioned, these cases were distributed over 3 different health systems. These cases represented patients who were dizzy, nauseated, confused, numbness, tingling, and they all lived at the same place. They all lived at the same apartment complex, and they were all suffering from carbon monoxide poisoning. This graph saved people's lives. And this graph came from our syndromic surveillance system. So this is an example of how automated systems, even if they're not AI, can be valuable in public health. Using the connectedness across the state, we've developed models showing which patients are shared by which emergency departments. We have a perfectly connected graph in Indiana, meaning that every emergency department in the state shares at least one, and usually many patients with other emergency departments. So this dispels the notion that all healthcare is local. People move around, and having health information exchange, having connectedness to multiple systems is super important to understand populations. If you want to study populations, you have to be connected to those populations. Using these models, we actually built a model. We built multiple, actually. We started with logistic regression, went to XGBoost, and you can see some of these here. We can predict before they become a high utilizer who is going to become an emergency department high utilizer in Indiana using these models. Again, these connections, this capability started because we needed to build out a syndromic surveillance system, but we didn't just use it for syndromic surveillance. We imagined what its capabilities could be for multiple repurposing. We also, in the United States, and I'm sure it's similar in New Zealand, every state in the country is required to report between 50 and 60 notifiable conditions to public health. We've studied this over and over again. Physicians and healthcare systems do a lousy job of reporting. Usually it's between 0 and 10% of the total disease burden are captured through these traditionally human reports. We built a notifiable condition detector back in 1999 that sniffed every one of these 3 to 5 million transactions daily. It looks at each of them and asks, is this condition reportable to public health? And why do we do this? Because physicians don't report for a variety of reasons. We know that hospitals and infection control personnel may not have visibility to all of the reportable conditions. This system has repeatedly proven that we can identify often more than 10 times as many conditions, case reports, as the normal standard system can. So we started this system just using rule-based approaches. We just wrote a bunch of rules. We evolved that in the mid-2000s to an agent-based fuzzy logic system. Most recently, of course, we wanted to look at AI and its ability to read clinical results and determine whether they are reportable. And so what we did is we took a pre-existing small model. In our case, we used Mistral 7B, and we trained it on these billions of HL7 laboratory messages. And by fine-tuning this existing model, we now have an AI model that automatically, without human supervision, can identify notifiable disease and report that to public health. We recently studied this and have a publication under review right now. This is a figure from that publication. Just gives you an overview of the data flow from the Health Information Exchange clinical sources on the left. It goes to the Health Information Exchange through our existing notifiable condition detector, which hasn't been fully transformed over to the AI piece. This is still the fuzzy logic. And then those that our current system identifies as reportable are sent to public health. What we did is, as I've described, we've taken positive cases. We decided to study 3 to begin with to get our feet underneath us. And we took positive cases plus a whole lot of negative cases to fine-tune that base model. We studied 4 different models. We studied a model that had 3 models that had single conditions, one for chlamydia, one for gonorrhea, and one for salmonella. And then we trained a combined model as well ideally, I don't want to have to run 60 AI models for each condition. We'd like to be able to build in multiple conditions into a single model. So what we did is then we evaluated its accuracy. Here's the accuracy. You're not going to have to memorize these numbers. The takeaway point is this accuracy is as good as and probably better than any human being can do. So our recall sensitivity is 99s. Our precision is in the high 90s as well. Again, these are, if you've ever looked at laboratory results, clinical results, and tried to decipher, is this reportable or not? There's some that we really struggle with. This did an admirable job. So what we are in the, and a couple of other points here. It's a complicated slide, so I'll just give you the takeaways. We looked at two different prompts. We looked at a prompt that said, hey, is there any condition in here? Even with a single model, we'd say, hey, you got any condition here? And so, for example, for the single model for chlamydia, when we asked specifically, hey, is there chlamydia present here? You can see that high recall, high precision. If we asked a non-specific question to chlamydia, is there anything here? Recall and precision were not great. We looked at the combined model as well. And the combined model, if you ask specifically to the combined model, is there chlamydia? Is there gonorrhea? Is there salmonella? Excellent accuracy. So where we've arrived at is moving forward, we're probably going to have a combined model that handles as many conditions as possible, and we will probe a question, multiple different questions for each notifiable condition. That's where we are right now. Certainly we're going to, there's so much explosion and evolution in AI right now that our approach is probably going to be different in 2 months. But this is where we are right now. So those are some of the examples of what we're doing. We're also part of the CDC's Vision network, which continues to provide effectiveness on COVID, influenza, and RSV vaccines across the country. We published one of the first studies showing the effectiveness of COVID vaccines in the New England Journal of Medicine early on in the pandemic. We continue to publish on the effectiveness. We just had a publication in the Lancet. Well, actually last year in the Lancet on RSV, and most recently on on pregnant women. And the effectiveness among pregnant women. So we continue to leverage this health information exchange, which connects clinical systems, not initially intended for public health purposes, but is repurposed for that. And we can produce data of the quality fit for the high-tier journals. And this data, believe it or not, still goes to the White House, and they use it to understand effectiveness. We're also involved in tracking the post-COVID conditions, folks with long COVID. And so we are actively recruiting, prospectively recruiting COVID patients, and we can also look back in time through our clinical database to identify folks as well. So we have a passive arm, which is retrospective, and we have an active arm, which is prospective. And we're in the early stages we have our first tranche of data, and we're actually working on our first publication there, but much more to come. Yeah, that's just information on long COVID. My last AI concept in particular, we all know that most people in the US anyways are testing for COVID at home. So often as a family physician, patients will come in to me and say, hey, I tested at home, my COVID was positive. That doesn't hit a laboratory system anymore. What we started to do is we've built AI models that can look at clinic notes, and we can see how many patients are testing for COVID, and then also how many patients are positive for COVID. If we tried to use older natural language processing technology, too complicated, too hard to build, too expensive. Building with AI took us about 6 weeks, and we have these models running. So we can at least get trends. This is certainly not this does not give us accurate prevalence or incidence estimates, but what it does is we can look at the correlation with other sources to understand when rates are rising. And so again, using AI, looking in clinic notes to identify concepts of interest, and it's much faster building these systems with AI. We also look for social determinants of health. Social determinants of health in healthcare systems is usually captured in inconsistent, unstructured ways. So again, we've built AI models that can look at the various determinants that we're interested in. And we've begun to use this in various predictive models to identify patients who are at risk of higher utilization, who are at risk of rehospitalization, et cetera. Again, these are being flagged using large language models that are trained to identify these conditions. Here's my closing point. Practitioners, both public health and clinical, when they use thoughtfully implemented information technology like AI, are more effective than the practitioner alone. I think that's very clear. I think it's simply stated, and I think it's important for people to realize. Am I saying that the technology is better than the human? Absolutely not. That's not what I'm saying. What I am saying is that the human is always better than the technology alone. But when we can augment the human with technology, we get a better outcome than human alone. So I think there's continued opportunity for augmenting what we do with these new emerging models. And with that, I'll turn it back over. Thank you.
Thanks, Shaun. That was a really nice last slide. I think it's one of the big questions on people's mind. I will never look at my dishwasher the same, knowing that there's a link there with Regenstrief. And I think you commented, you made a comment about if you want to study populations, you have to be connected to those populations. And I think that's something that we miss quite a bit. We usually get so siloed looking at the data that often we miss that connection component. Yeah, so thank you very much. That was a great presentation. And we'll open the floor to some questions. Morning, Peter.
Thank you, Shaun. I found that fascinating. I really enjoyed that. I'm just not sure. I just want to get my mind clear on something. So, like, with the notifiable conditions that's able to estimate. So, like, does your system like send a report every day or every time it finds one to the notifiable conditions office, or do you accumulate them for a month and then send it away? And do you do any checking before you send the reports away, or is it got a freelance to send everything away whenever it finds something?
Yeah. So we receive data in real time from hospital systems. At the same time a lab is sent into the electronic health record, it gets sent to the HIE. So what we say is we have no more than a 15-minute lag time because it has to go through the HIE processors and all of that. But once that is adjudicated in real time by our notifiable condition detector, it is forwarded to public health. So it is a real time, it's not a batch report, it is a real time report. Validation. How do we validate? Well, it turns out that, we talk about with AI now, we want humans in the loop. I think humans being in the loop are super important right now with AI. We have a human in the loop with notifiable disease detection. That human is the state epidemiology department. And so we meet with them regularly to go over any questions that they have to make sure that we are both generating lots of true positives and that we don't have any false negatives. So our health information exchange does report, but we still have a reporting law in Indiana that requires providers and health systems and laboratory systems to report. So they all do that. Everybody knows that the HIE is doing it, but folks still do reporting. So we can also look for false negatives that way as well. So there's an ongoing natural human in the loop monitoring of this process. And in fact, actually, one of the ways that we train our AI is we get our adjudicated lists from public health. And so here is a human adjudicated list of known positives and known negatives, and those known negatives are going to be the results that we sent to public health, and they were false positive. And so we actually have an ongoing source of training data for these models.
Fascinating. Thank you.
Yep.
Thanks, Shaun. I'm just cautious of time. There are a few questions in the chat, and the questions and answer down the bottom there. If you have time to.
Sure.
Actually, if I may leap in there, our next presenter doesn't appear to have joined us yet. So I'm tempted to call this their loss, at least for the moment, and say you can carry on answering questions to your heart's content until there are no more questions or we have the next presenter. So please carry on.
Sure, great. I'm going to have to read through these.
I can read them for you.
Good. I have to take this one. Absolutely. Claiming 99% on anything with AI sets off overfitting alarms. Okay, perfect. Thank you. So here's an example. I completely agree with you. And when we saw these numbers, I said, no, we're something's wrong. With chlamydia, it turns out, 10 years ago, chlamydia, you took a swab, put it on agar, and you let it grow, and you had the laboratorian type in a very long report that said, no colony forming units, etc., written by Mary Smith from this lab, all human typed, right? Well, 2016, it turns out that the CDC began recommending nucleic acid amplification tests, which produce what? Positive, negative. Okay, the AI locks right in on that, and it turns out that there may be patterns that are correlated, but strongly correlated. And my ultimate response to the overfitting is, we're seeing every result in our state. So we are fitting exactly to the data that we'll be receiving, okay? So when you see the whole population, it's not overfitting. It's adapting exactly. Now, do we refit? Do we retest? Do we train? Absolutely, we need to, because there's data drift, no question about that. But in the instance where you see the entire population, it is not a sample. It is the full view, and we have about 98%. So I'll admit that about 2% slips through, and so we don't see that. But when you have the full population, it's not overfitting.
Good answer. Thanks, Shaun. We have another question here from Chris. I'll read it out. Great stuff, Shaun. Agreeing with Envy over here in the UK. It sounds like you've indirectly built a system that Peter Singe would call a management flight simulator that creates organizational learning across your hospitals and public health. Does this feed into your continuous professional development of staff in a structured way?
That is a great question, and I'm going to give you a disappointing answer. No, it does not. We are a part of some coalitions of public health coalitions and establishing best practice. And so we do, individuals are aware of this. We do share trends, but I would love for this to be a much more formal process with our public health and clinical community. People are busy and there are priorities, and right now I think people feel like it's not broken, so don't fix it. It is broken. Public health is always broken, and so that's not a great attitude to have. But I appreciate the sentiment in the question, and I completely agree that this needs to, the type of information that we generate, the trends, the knowledge that we see here is super important and needs to be more formally disseminated.
Yeah, thanks, Shaun. Further to that, do you see that some practitioners, health workers might be scared or avoiding AI because they don't know about it?
That is a great question. Of course, I think there's a lot of fear, uncertainty, and doubt out there. We call it FUD, fear, uncertainty, and doubt about this technology. I think we are right to be skeptical. I am skeptical. But a lot of what we're doing right now, I call it measuring the mass of the electron. What does that mean? Well, back in the 1800s, we knew there was an electron. We had no idea how much its mass would be. But we just, sort of presume that. But eventually somebody had to measure the mass of the electron so that we could get on with things, and that knowledge could then help us. Right now, our measuring the mass of the electron in AI is figuring out how well it works, under what circumstances, using what processes. And I think there needs to be a lot of that. I call that evidence-based best practice guidance. We need to generate a lot of that. And so I think we should be skeptical. But I would also say, I never thought we would get here in my lifetime with AI. What's happened over the last 5 years is, I think, nothing short of fantastical. Now, there is a lot of learning to be done, but the capabilities, the creativity and efficiencies that this is creating is incredibly powerful. And the good news is, today the AI is as bad as it will be, because it's only getting better. So
interesting. Thank you very much. I see David's still not with us, so we'll continue with some questions. And I see Barry's got his hand up.
I think you're on mute.
You're still on mute, Barry.
Sure. Thank you for an excellent presentation. One of the issues that comes up in New Zealand is related to one of the questions in the chat, is how do you get consent to use the data? I mean, in New Zealand, we have issues about ethics of using health data, and it's something that certainly we're very interested. I mean, you're pulling data from all sorts of places, doing wonderful stuff with it, but the consent and ethics of sovereignty.
Yeah. The consent is, I think, a local, cultural, social phenomenon, right? We all know that. Different groups, different social norms influence what our consent is. I just have to start by saying that. Say there is no universal right answer to this question. I think there are adaptations to local cultures. In addition to the work I do in the US, I am also part of our global health team, and we help developing countries build out their health IT infrastructure. And we talk a lot about this. Now, specifically to your question, how do we do it? So our health information exchange began back in the late 1980s. And it was the first use case we developed was to make sure that emergency department physicians had the most comprehensive data on the patients they're seeing in front of them. They don't know them from Adam. It was a clinical use case. The second use case was notifiable condition detection. So we established trust and value in our system first. Once people trusted one another, then we could move on to other use cases. In our model, we are an opt-out model, meaning by default, people's data will be used unless you opt out, okay? So every person has to sign a form when they come into the hospital. Part of that form gives permission to use the data in the health information exchange. To date, we have had, out of the millions of patients used in the system, we have had about 14 people opt out of the health information exchange. So the other part to this is health systems have begun relying on the HIE for their business practices. So they pay the health information exchange to transmit the result from the laboratory to the clinic. Otherwise, the hospital would have to pay for that. The HIE does it for much less expensive. So there are many business reasons where the HIE must access and transmit the data, and in some use cases persist. So believe me, I've been at many conferences where this topic is discussed, and not everybody agrees with this approach. Absolutely. But our approach is patients must explicitly opt out if they don't want their data used, and we've had very few people do that over the years.
Thank you.
Once it's, I guess, but that's only part of the answer. Once I realized as I got to this point, we have a management committee that oversees all of the uses of the data. The Regan Streif Institute, who created the HIE, ran it for the first 10 years. Regan Streif is charged with all of the research use cases of this data. And so we provide oversight for any research question. There's an IRB process, et cetera. So we follow those. For treatment payment operations, so we kind of think of there's research and then there's TPO, treatment payment operations, which are the daily. The Indiana Health Information Exchange and our management committee decide what other use cases the data will be put to. Those are individuals like the chief information officers, the CEOs, the chief medical information officers of these organizations have to make a decision. Are we going to share clinical data with our health insurance providers? Yes or no? And each organization gets to make that decision. And if an organization wants to pull out tomorrow, we've designed the system in such a way that we can actually flip a switch and all of the data from a given organization is gone. So we have a number of controls in place. I love talking about this question, Barry, and would love to at some point be able to have a beer and talk more about it.
Sounds good, Shaun. Barry drinks champagne, by the way.
Oh, hey.
Last question. Can your AI system help us to detect large outbreaks in like Legionella OB from cooling towers?
Oh, yeah. So yes, our notifiable condition detector, Indiana, this was several years ago. Indiana had an HIV outbreak in a rural area that caught a lot of people by surprise. But what didn't catch people by surprise was the uptick. Our notifiable condition detector identified that. We actually had, I don't know how close you follow the public health stuff in the States, but in Flint, Michigan, there was a large prolonged lead exposure outbreak in the community that went undetected. In Gary, Indiana, which is another lower socioeconomic status city in general, Gary, Indiana, by Chicago, they had a lead exposure outbreak. We caught it immediately because of our notifiable condition detector. So yes, it absolutely can. Again, if you can see what's happening in the entire population, and you have good detectors, then yes, absolutely it can help identify that.
Nice. Thanks, Shaun. And I think that goes back to your comment about if you want to study populations, you have to be connected to populations.
Yeah.
Nice. Well, thank you so much for your presentation and your extended questions.
Sure, my pleasure.
It's absolutely wonderful. We have had an apology from the next speaker, David McVie, who couldn't attend, but I'm sure he will come along to our next conference. Just a reminder for our Menti quiz. Patrick, is that a nice plug? There's a link in the chat, I believe.
There will be a link floating around the chat, and I can drop it in again because I can.
Nice. Thank you very much, and thanks again to Shaun. And I'll introduce our next speaker. Good morning, Kenyon. Kenyon directs the innovation and growth at the intersection of health and artificial intelligence across the federal health sector. As a health informaticist, Kenyon delivers cutting-edge programs and solutions merging health data science, information system design, and responsible AI to federal clients. Before joining Accenture, Kenyon served as Managing Director of Digital Health Research Centre for Excellence and Health Insights AI Lab at the University of Maryland. And your presentation is titled Health plus AI, Public Health Workforce, Core Components of Public Health Reinvention. Good morning, Kenyon.
Good morning. How are you doing? Am I coming in loud and clear?
You are, yes, and we see your slides on the screen.
Okay, perfect. Well, thank you for having me here. I'm delighted to join this wonderful event and then share some reflections on how humans and AI can work together for public health. Let me just jump right in. So to give a little bit of perspective, I'm a health information scientist by background, so study how we can use information to impact health and wellness across a variety of domains, especially when we think about behavior and systems adoption. For the last, I guess, about 4 years, I lead the health data and AI practice for Accenture Federal Services, where I'm helping federal health agencies modernize and reinvent. So we work with US CDC on their data modernization initiatives, working with NIH on some biomedical discovery related programs, and then work with large complex health systems like the military health system and VA to help them use AI and machine learning in new ways and develop solution architectures that can support a variety of analytical workflows. Also information systems faculty at the University of Maryland. And before that, I was in academia and had a digital health research center and AI lab at the University of Maryland, and did a few other things, including working for a federally qualified health center network and homeless clinic that initially got me really excited in health and set me off on a career about 20 years ago. But when not doing that, I enjoy kayaking, snowboarding, concerts, and such. And I have a wife, 2 kids, and 2 cats, and was a former caregiver for Alzheimer's patients. Was also eye-opening for healthcare. So I think even when we look around, this is the age of agentic AI, right? We hear it every day. We've moved from AI, and now it's talking about agentic, and so we now have this ability to learn and adapt, or have our systems learn and adapt in real time that can change the way that organizations operate. And this is especially relevant for public health, which is consistently looking for sort of ways to better manage data, monitor threats, respond to a variety of diverse needs across communities. And we'll talk a little bit more about that. There's that. And this next slide, and this refers more broadly than public health, but it's across a survey of over 4,000 individuals, executives that we had conducted. We asked them, to what extent their organizations are going to be adopting things like Gen AI tools and AI co-pilots and AI agents over the next 3 years. And you see that, almost 41% are significantly going to be adopting them, 6% fully, and then some partially. So I think the bottom line is this is coming across the commercial landscape, which is typically a leading indicator for some of our federal health programs. And so when we think about how we're going to reinvent with the agents, it's not just dropping a technology solution into the mix. We need to fundamentally think about how we're reimagining the work, right? So understanding what are the needs, what are the processes, and how do we identify the specific data and automation technology for every aspect of the work. We need to reshape the workforce itself. So I know the question came up on the last presentation about sort of how are we doing that with employees and those new skills. So to make reinvention and public health reinvention possible, have to bundle that with upskilling and changing the knowledge capital of the organization. And then there's the redesign of the workspace itself. So what are the actual solutions, the technology, the infrastructure to make all this happen? And all this sort of operates on top of what we call the enterprise data layer. So that is the information, the insights that we're bringing together in a way that these tools can access them. So I want to talk a little bit about sort of what are autonomous agents and why are they important in public health. So these are AI tools that can understand their environment. They can understand the intent of operators and then take actions and reason to complete these goals. Some of the characteristics, a human may set the goal, but an AI agent can act independently to achieve those goals, and they can adapt, which is different than many of our past computer software systems. And they can reason through ways to accomplish these goals and create different plans of actions and have access to a variety of tools to complete those tasks. They also are able to utilize long-term memory and reflect, so to continually to learn and adapt and take feedback from humans to continue to refine how they operate. And then they have communication capabilities, right? This is the ability to communicate either agent to agent or agent to tools or agents to humans. And being able to enable those communications and multi-agent configurations is a key part of this process. So when we think about these agents and what are the functions they're actually going to be impacting in an organization, this chart is taken from the same survey I mentioned a moment ago. And you can see, modernizing functions and integrations is at the top of that list. Assuring the quality of digital functions and systems is at the top of that list as well. And I think when we think about how to ensure quality within systems or data, that's been a persistent problem with public health when you have such a diversity of different systems that are trying to bring data together at a national, especially at a federal level, at a national scale, when you have communities and states and jurisdictions that are doing this differently, getting a consistent view of that data has always been a problem. And so this is a very exciting opportunity to bring agentic to use. And then thinking about what are the automations that are going to be most useful. And so automating how we communicate to those under threat for communications or under threat from public health threats is also an exciting area. Let me keep moving. I know this is a short presentation. This next slide, if we think about sort of the roadmap to where we came, I mean, this, if you look at the far left side, I mean, this is probably a 20-year period, but then we're very compressed. In the age of generative AI, we think LLMs really just hit the stage in a sort of widespread way, about 2 years ago. And then now with agentic, because the LLMs are now having capabilities to communicate and reason and act. It's a new age, and we think so. Traditional AI, we've had for a while the ability to do outbreak spread prediction, risk stratification of different populations, environmental health monitoring, being able to make sense from sensor data. And then as generative AI has impacted public health, we have things like multilingual health communications to more rapidly provide that to different audiences. Public health chatbots are on the rise. Many public health departments are now deploying these for their citizens using technologies like RAG, where they'll take a trusted corpus of documents or trusted set of public health guidance and make that available through a chatbot. And then looking forward, for agentic use cases, we things like data integration agents, which can more automatically pull different types of data. That could be multimodal data from social media or data from Shaun's HIE or elsewhere, and then bring that together and make sense of it. Agents which can support all the complexities of response when we do have outbreaks. And then having specialized agents that can investigate the causes of outbreaks, support contact tracing, being able to continually reason across these big data sets. And then there's an unlimited way of human and AIs teaming in the future, and we'll talk about some of those further. So at this point, let me provide a little more background on agents and how agents operate, because I want that to be a key takeaway of this. So when we think about the agent hierarchy, there is what's called an orchestrator agent. So these are agents which can assign tasks to other agents, and they can act as a coordinator. You can think of them like a quarterback of a team or a center half of a football squad. And then there's utility agents. These can understand user intentions and the goal. They can be designed to have singular tasks, or they can be designed to access a variety of tools. And the orchestrator agent is directing and coordinating that work of the agents. And then the individual tools, these could be things from specific analytic plans. These could be things like data standardization tools, tools that can launch communications like emails or scheduling. But we think about these as some of the core building blocks. And then there are 4 distinct capabilities of an agent. So one being the ability to perceive, right? Be able to understand and interpret what that goal asks. 2, the ability to reason. So when we give it a problem, it can produce a plan and then creates a plan of action. And as part of that plan of action, it accesses both tools as well as memory and a set of those historical interactions to decide how to act. And then taking all that together, it decides to act, and then it'll give an answer or an action. And in order to build one of these solutions and deploy them, the tech stack must be considered. And so I spend a lot of time these days helping sort of federal agencies and partners sort of build these tech stacks. And the nice thing is the large part of these tech stacks are available through natively through the hyperscalers, but there's also a number of bespoke firms that are making these tech stacks accessible. And I'm sure you've seen, I mean, the ability to build an agent in no code environments is becoming quite popular. So solutions like Google's Vertex, you can just get in and sort of direct an agent and build it. But the takeaway from this slide, so four key components of that tech stack. There's the underlying data infrastructure, and you want that data infrastructure to be able to embed information, be able to support things like vector similarity search, structured query access, and the memory management. Then you have tools that sit on top of that data infrastructure that enable things like reasoning, the communication and routing for interfaces, support your API management. And then on top of those tools, you have the orchestrators, agents, and models themselves. And you see some of those key players I'm sure you recognize on the far right there, OpenAI, Anthropic, the custom LLM models from folks like, such as Claude, Llama, Gemini. And then on the interaction layers, that's where humans humans or other computers can interact with these models. I think the other point, when we think about this, the choice of LLMs themselves, I think one of the sort of interesting things and something to think about when one's deploying and building these technologies is, there are trade-offs between different LLMs in terms of you have large parameter models, you have small parameter models, which may be more or less fit for purposes, but for each of these design choices, there's different token consumption patterns. And so if you think about one aspect of responsible AI being sustainability, that suggests that we want to choose the model performance trade-off that uses the least amount of energy. And with many of these current stacks, they have what's called switchboards, or sometimes they're called model gardens, that allow you to switch out models and rapidly test multiple model configurations quickly, so that you can choose the right, or I'd say choose the optimized model performance characteristics, which is a nice feature of these as they've developed. The other sort of key takeaway when we're talking about sort of how these agents will function within the world, within a public health environment, has to do with agent communication methods. Right, so you may have heard the term Model Context Protocol, or MCP, recently. So this originally emerged through Anthropic less than a year ago, but it's really taken off to be the standard for how different agents can access, use, and share information between tools, databases, and external APIs. I mean, typically you'll have a sort of standard like an MCP server to enable that. Sometimes within the existing platforms that support analytics like Palantir, those can function as an MCP server based upon some configuration of those. So the MCP, agents connecting with these other services, but then there's agent-to-agent protocol. This was something that Google had pioneered, and this focuses on the direct communication and collaboration between different agents. Similar to how we don't want our health data to be locked in silos when different public health agencies need them. We don't want our agents to be locked in silos either. So by using these standardized communication protocols, that helps promote interoperability and reuse. And if we think about sort of what this looks like as given a traditional process that's stepwise, you know, on the left, it's pre-wired. You can, I mean, you can put some rule-based algorithms within that flow. But then you look on the right, when you see this autonomous intention-driven, it allows for a much more flexible and performant way to complete tasks and complete more complex tasks. Right. I think I've already talked about some of that, so I'm not going to go deep in that, but I do also want to show you when we think about multi-agents and human configurations, there's sort of three sort of primary styles that we're currently implementing. On the left, you know, you have a human that's overseeing agentic workflow, and that's you know, agents are working through a process. The human has visibility into how those agents are performing and provides oversight on that performance, and then intervenes if necessary, if some output or action is questionable. You know, you have the sort of an individual working with individual agents, so where a human will set the goal and then interacts with individual agents, essentially like assigning tasks, and they report back. And then you see sort of, this is less frequent today, but you're seeing sort of more of that, and sort of this will probably be one of the sort of primary archetypes in the future, when you have a collaborative group with a human and multiple agents, where they're each sort of divvying up the work and working together in collaboration. Let's see, I know we're running short on time. I think I can skip that. So this too, I wanted to sort of give you a sense of sort of what some of in the federal sector, some specific agents that we're developing and prototyping. When we think about sort of the need for data and IT development and modernization, and I'll cover this IT transformation agent. So we have we call our engineering aid, which is an orchestrator agent that'll work hand in hand with a human developer team to help them do things like generate the code, translate what they want to do into the technical artifacts. You know, there's a large legacy problem of poorly documented code. I mean, using these technologies now, you can ensure that your code is properly documented and can be reused and understood, not only by computers, but also by humans who might try to, you know, reuse that in the future. So some specific agents that would be used in this type of scenario, the developer agent, which is supporting the coding process. You have the writer agent, which is specially designed to produce technical materials and documents, and you can engineer it to be in specific styles by agency. You see the use of quality control agents. We do this in many different ways now, but essentially you want to have an agent that's checking the output of the other agents to run that through some specific QA test. And then lastly, on this IT transfer, using a UI generator agent to help sort of quickly mock up different screens and interface styles to support that testing. The last thing I want to cover, because we're running about, I think we're good on time. If we think about a public health threat use case, what this looks like in using agentic. So on the mission planning side, you can leverage the real-time agentic workflows to monitor and adapt to new information. And that new information, again, can come from a variety of sources, but the agents have the ability to make sense of it regardless, and then also has the intelligence to be able to sort of influence or order, or at the very least sort of advise what the predicted needs are for logistics and resources. The agents can also simulate dynamic situations of action. You know, we know that, you know, public health threats can, you know, go a variety of ways, but the agents can help sort of do that scenario planning. Using agents for the tasking of like geospatial analysis requirements. You know, in the US this past year, we had a hurricane hit the mountains, which created unprecedented flooding and roads wiping out. So, and I remember in that sense, I was talking with some folks from FEMA, hard to even know sort of where one, could travel or not travel. So you could use this agents to help dynamically get that geospatial analysis from satellites to support that level of insight. And then again, being able to summarize that. And then in managing, the threats, synthesizing, prioritizing, escalating, helping provide those recommendations, and then, communication pattern monitoring and support, just as one example. So I think we're coming up on time. I know that was kind of a rapid fire run down agentic, but let me pause there, and then I'm happy to take any questions.
Thanks, Kenyon. It was a wonderful presentation. It's really interesting seeing just how advanced it's become. And I see Barry has his hand up.
Kenyon, wonderful presentation, and thank you for attending. And also nice to meet you, almost in person. One of the things both you and Shaun mentioned, which I think is worth discussing, is that when AI came up, and particularly in public health intelligence, people were saying, well, there's no place for the human being. The AI will do the whole thing. And yet both of you have emphasized that really it's complementary. It's doing, it's a tool. It's doing some of the groundwork, not just groundwork, but you still need us doing stuff. How do you allay the fear that people have that there'll no need to be health intelligence agents? People will just let AI do the machine do the whole thing.
Yeah, I think that sort of dynamic of how sort of you build trust, but also allay fears, because I don't think you have to be transparent, because I know, like say, we'll reskill and transfer, but I think at the end of the day, there are going to be certain types of positions that are likely, not going to be the same or gone in 10 years, 5 or 10 years from now. And the people who did those will, have to transition to other types of work. So I think, from our point of view, when we're thinking about sort of the workforce, it's thinking sort of what skills are needed to make them sort of most value out of the use of these systems in the future. How do you sort of help people reason? How do you sort of orchestrate that dynamic between individuals? How do you think about sort of what are the sort of information models that people need to understand to be able to effectively work with them, and try to sort of help support that reinvention of the workforce. But in terms of like certain roles, I think there's I don't think typists are probably ever coming back. So I don't. It's an interesting question. I don't have a sort of I think a better answer than to say. There's going to be some reskilling. There's going to be some displacement for some types of roles that the AI maybe makes more sense at. But there's always going to be things that I think humans excel at and humans do well. And one of the things that we've seen in public health is, you have limited capacity to support certain populations. And if you can sort of triage the sort of support of sort of intervention, delivery to different populations, and have sort of more human engagement with those folks than, they in the past, or now they're worried about just documentation. We see that in the healthcare side quite a bit, and see that some of that same transition. But yeah, I think that's what I have to say about that.
Thanks, Kenyon. That's a good answer. Last question from Srinivas. He asks, good presentation. Can AI detect and warn public health experts about unintentional and accidental injuries, exposures to hazardous substances used by public at their homes without hospitalization or coding?
That's an interesting question. I think to the sense if there's signals from certain environmental health threats that might show up in the hospital record, sure. But if we're talking about outside of that, I think there are certain health threats, like, for example, when wildfires are spreading, the risk for asthmatics goes up quite dramatically. And, through different surveillance with geospatial and satellites, and then using AI to be able to predict that, you can see that. Similarly, we can see if things like regions that are supporting sort of shellfish production and farming have enhanced algal blooms, then that will, you can predict that, there will be certain sort of foodborne illnesses that may show up and try to get ahead of it. I mean, in terms of, I think I heard the question, like if there's environmental contaminants actually in the home, was that part of the question? Yeah, it's interesting. I mean, I think it depends on the type of monitoring. I mean, people, are putting more sensors in their home every day. You have, your Ring cameras, and you have, video watching people coming and going. I don't think it's a stretch to think that folks are gonna, if they have the ability to monitor things like air quality or water quality in their home, they wouldn't do so. I know at ARPA-H now, our Advanced Research Project Agency for Health, there's a whole initiative now that's focused on indoor it's air quality, but I think there's some more water quality, but it's essentially sort of the environments in large buildings, how we can better understand when there are threats emerging in that space. And so if you're interested in that topic, I'd check out what they're funding in that portfolio. But I think it'll come down to like what sensors we have as part of it. And then when we know the outcomes in terms of the types of illnesses folks get from that, then we can make inferences of where it came from in the future, most likely.
Great. Thank you so much, Kenyon, for answering that question and your presentation this morning. It was absolutely wonderful to hear from you.
All right. Thanks so much for having me, Tim and Barry and all. Patrick.
Moving on to our next presenter. So the last presenter for this morning's session. We started with the legendary Bev, and then we expanded our horizons to Ireland and Northern Ireland with Paul and Aaron. And then went over to the Ditch with Shaun from Indiana and Kenyon just now from Maryland. And now we're bringing it back a wee bit to hear from Dr. Mark Jacobs from Fiji, I believe. Are you online, Mark?
Yep, I'm here.
Wonderful. Thank you very much. Mark is the WHO Director of Pacific Technical Support and the WHO representative to the South Pacific. Welcome, Mark. Your presentation title is Surveillance in the Pacific, which is going to be very interesting, and I invite you to do your presentation.
Great, thanks very much. And just checking whether my slides are showing.
Yep, yes,
okay,
cool. Good. We see you.
So it's great to be part of such an interesting session and impressive colleagues from around the world, and it's also very nice to see some old friends and colleagues. Well, I guess I should be fair and not overemphasize the old word in that. But anyway, Bulavanaka from Fiji. I will get underway now. Of course, the topic of surveillance in the Pacific is a very broad one, and it's also quite a deep one. But I'll be skimming over the surface, if you like, just sort of talking about some of the key issues and giving a bit of an oversight of where we're at and what some of the challenges are and what are we doing, rather than getting into the fine detail. Just trying to get having difficulty getting the slide to move along. Oh, there we go. Yeah, so I'll just talk a little bit, just very briefly, about WHO in the Pacific and our role. Then I'll talk a bit about some aspects of surveillance in the Pacific, communicable disease related, NCD related surveillance, and climate change and health. And I'll finish with a couple of comments about some cross-cutting issues. Now, for those that aren't as familiar with this part of the world, so this is a map of the WHO's Western Pacific region. So it's a reasonably diverse region because it includes, well, now the country with the second biggest population in the world and the country with the smallest population in the world. It includes 21 Pacific Island countries and territories or areas. And we have a number of offices in the Pacific. We have the big multi-country office here in Fiji. There's country offices in the Northern Pacific, in Federated States of Micronesia, in the Solomon Islands, and in Samoa, and there's some small liaison offices in 3 of the countries. But the office here in Fiji, we directly support 12 of the countries and territories, and we provide sort of technical support to the work of the other country officers in the other 9 countries and territories. So to give a bit of an idea of the scale, so we're responsible in this office for like supporting the Northern Marianas, and we're responsible for supporting Pitcairn Islands. So the distance between those 2 is about the same distance as London to Cape Town, just to give a bit of a sense of scale. So just a few broad challenges that relate to surveillance in the Pacific. Of course, there's a huge breadth of threats and health priorities. There's very widely dispersed populations, not just across the region, but within countries. Many of the countries have ongoing challenges around their workforce capacity, and similarly, there's been long-term issues around laboratory capacity. There's still quite a bit of health information system fragmentation, and a number of countries also rely on a mixture of paper-based and digital health information. A lot of the countries are updating outdated legislative frameworks, and it's the use of the information, the surveillance information, to then generate action is patchy. So onto the communicable disease surveillance area, just very briefly, and not surprisingly, that's quite a big focus for our work in the Pacific. One important thing to mention is it's not just about WHO working with countries. There's quite a long-standing and very strong system of Pacific regional architecture in health in general, but surveillance specifically. And particularly, there's decades of working very collaboratively with a Pacific regional organisation these days called the Pacific Community, and its abbreviation is SPC. Anyway, so our approach, our work in surveillance is very much a collaborative work and building on those long-standing partnerships. And of course, we focus on trying to build national capacities, as well as strengthening regional approaches, and also helping countries with their data analysis and also their information sharing within the countries, between the countries, and globally. So just a really important example of the Pacific regional architecture. There's a Pacific Public Health Surveillance Network, or PPHSN. It's long-standing. So when I used to work at SPC more than 20 years ago, this was already in place. So it's been around for a long time and playing an important role. And there's a very active collaboration between WHO and SPC, serving all of the Pacific countries. And there's a number of other institutions that are also actively involved, and there's management committees that involve countries. So countries take it in turns being on if you like, the board for PPHSN. And there's a number of different areas and different networks within PPHSN. I won't go through the detail, but there's PACnet that's around alerts. For instance, there's laboratory network, there's EpiNet, and so on. It's a big, well-functioning, very collaborative system. We also have a regional system for syndromic surveillance, and there's weekly reporting of 6 core syndromes across all of the Pacific Island countries. And that's again been in place for quite a long time. And there's weekly reporting that's available from WHO on what is happening, so people can access those data. Similarly, there's the hospital-based active surveillance system, which focuses on a number of vaccine preventable diseases specifically, and that again has been in place for some time. There's also quite a bit of work that gets done in terms of open source approaches to public health threats, and we use that, for instance, in particular for when there's mass gatherings. So, I mean, mass gatherings in the Pacific, of course, are of a slightly different scale to mass gatherings in China or in India, but there are a number of different things that bring in people from countries right across the Pacific together and in close contact. So, for instance, in the last 12 months, we've had a Pacific Island country host a meeting of all of the heads of government from the Commonwealth countries. We've had a mini games in Palau and so on. So this is something that we work very closely with the host country to really strengthen their surveillance for these sorts of events. And so, for instance, for the recent mini games in Palau, and don't be concerned that you can't read the detail in the table, but it's really just to illustrate that there's numbers of things that get monitored and reported through these processes around major events. The things that we saw most in Palau were ILI and acute gastro, and also some heat-related illness. But the surveillance includes things like social listening and so on. So that's also a well-practiced system, and it works well in a Pacific context. There's also alert dashboards. Again, you won't be able to see the detail, but these are all available online for WHO. Again, drawing on the information that's regularly reported from all of the countries. So I guess that's another thing to say, is because this is very much a collaborative approach, there's not reluctance of countries to report into it. So it's very much seen as being a shared resource for the Pacific. Just an example, a specific disease example. This is dengue, and so we have dengue outbreaks in some years in the Pacific. We don't get big surges in every year, but some years we get really quite big multi-country epidemics. We're in one of those years this year, and we've had more than 12,000 confirmed cases so far, and outbreaks in many countries in the Pacific. And we can track that pretty well, which of course we need to, because one of the actions, I guess, that gets triggered by the indications of things like dengue happening is we start mobilizing both additional resources that we can help countries with, but also talk to other donor countries if there's particular need. So they might need some experienced clinicians to come in and provide some guidance or whatever the issue is. So it enables us to get ready for that. One of the other things, just for interest, is we also get access to surveillance systems for some of the Pacific Rim countries, not the detailed surveillance system, but for instance, New Zealand has a weekly report that looks at dengue cases in people in New Zealand who are returning travellers, and it includes information on what countries they've been travelling in, and so we get that every week. And so sometimes we get early warnings of something happening from that other information. So we do actively try to capture information from other sources. Malaria, of course, we track. There's 3 Pacific countries that have malaria still, PNG, which we don't actively work with, but also Vanuatu and the Solomon Islands. Of course, vaccine preventable diseases, particularly measles, we also track very closely. This is just an example of an outbreak from a few years ago. We have seen a few Pacific countries get explosive outbreaks of measles in the past, and it's something obviously that causes quite a bit of concern. But in the surveillance area for communicable diseases, we don't just look at things like cases. We also look at other aspects, like we have surveillance of vaccination coverage, for instance. So there's regular reporting from countries of vaccination coverage for all of their key childhood immunizations, and we monitor that. We put together reports which we share to the countries. We monitor progress. We look at which countries might need some assistance. So this is just an example of the data that we have just for measles and rubella containing vaccine. And then we have surveillance around neglected tropical diseases, and this serves a different sort of purpose. The surveillance for most of the NTDs are around whether we can demonstrate that countries are moving towards eliminating the NTDs. And so this tends to be based on surveys. And then there'll be mass drug administration programs and then repeat surveys. And so then if we can demonstrate through all of that a country has no longer got a particular NTD, then that gets recognised as having eliminated. So that's that purpose. Now, the sorts of things that we were working on in particular, and I probably should speed up a bit, so I won't go through this, but it's the sort of things that you wouldn't be surprised about. Laboratories, for instance, is a big focus, and I've got a slide now on laboratories. historically, a lot of the Pacific countries have had quite limited domestic laboratory capacity and a big reliance on laboratories in the Pacific Rim countries, which of course it means that there's shipping costs, there's delays, there can be sometimes uncertainty about whether the receiving laboratory is able to do the test, all of those different sorts of things. Now, over the last few years, there's been a big focus on improving domestic capacity, and that was actually enabled by a lot of the support from donor countries, including New Zealand and Australia and a number of other countries, to strengthen domestic laboratory capacity because of COVID. And so now all the Pacific Island countries and areas have got molecular testing capacities onshore. They've all got gene expert capacities, which they're still using. There's 9 of the countries that have got active open PCR programs. We've installed containerized laboratories in a number of countries, and we've got development of genomic sequencing capacity in 4 of the countries, and in Fiji that sequencing capacity has just been opened just now, so that's now functional. NCDs, just very briefly on this, of course, there's a huge burden of NCDs in the Pacific that many people on the call would know. And our focus there looks at trends in terms of health outcomes, also risk factors, but also there's like programmatic surveillance, if you like. So there's actually surveillance of how well countries are implementing the key actions that they've agreed to implement. This is just a slide of very high rates of obesity and overweight in children and adolescents in the Pacific. I think 9 of the top 10 countries for rates of obesity in the world are Pacific Island countries. Similarly, we track the risk factors like adult smoking and different sorts of things like that. So we have lots of information on this. But the sort of focus that we have in working with countries, we work with countries on doing regular NCD risk factor surveys called STEP surveys. We're currently setting up a childhood obesity surveillance initiative called PHONZ. We're doing work on tobacco-related surveillance. We have a surveillance framework around those policy actions in countries. Anyway, so I'll just very briefly a couple of things on that. Again, you won't be able to read this, but this is information on the STEP surveys, so the NCD risk factor surveys. And so these are quite big deals. They require quite a bit of technical support and quite a lot of funding. The aim is that we help countries run these every 5 years, but for a number of the countries, it's more like 10 years because it depends on availability of funding. But these produce, of course, very important trend information. This is just a slide on this PHONZ, on the Childhood Obesity Surveillance Initiative. It's a new bit of work, but I think that the focus of it is pretty self-evident from the title, and it's a big issue in the Pacific. This is now getting into again, you won't be able to read this, but this is getting into the tracking of the policy actions, and this information, it generates slides that look like this. Again, they look super busy. But basically what this is a dashboard or a traffic light depiction of how every country in the Pacific is going against the agreed policy and program actions on tobacco, or on NCD. So there's a line there on whether they've introduced tobacco excise taxes. There's a line in there about whether they've reduced salt consumption, various things like that. And so we track this and we report on it annually to health ministers or to the heads of the health ministries. So the idea is it's not just interesting for us. The idea is that countries can see how they're comparing to other countries and to provide a bit of motivation to do more if there's lots of red and yellow in their country column. Just very briefly on a little bit on climate-related surveillance in the Pacific, because it's another area that we're working on. So, I mean, I think as a lot of people would know, the Pacific really is on the front line of the climate change and its impacts, and climate is already affecting communicable diseases, affecting NCDs and a range of environmental health threats. And the purpose of surveillance in this context is to really help with early detection of some of these threats. But it's also and to enable timely responses, but it's also about further strengthening the evidence base for why meaningful action needs to happen. And certainly if we look at things like climate resilient health systems, and so that's a big focus for us, is helping countries build more resilient health systems. Surveillance is an explicit focus in that work. It's not an add-on. We see quite a few climate sensitive diseases in the Pacific, not surprisingly, and I don't need to go through this just in the interests of time. One of the things that we're working on is trying to link meteorological data with health information. And so we're trying to build systems around that in a number of the Pacific Island countries. And again, that's about trying to help with early warning for some of these climate sensitive diseases. I won't go through this in detail, but this is just an example of how we're doing this with Fiji. And there's now platforms in place for both patient level data collection, which can then be shared, and it's all electronic. But there's also a platform where this can be displayed using GIS data, and we can sort of use it for displaying various levels of risk and so on in this sort of space. And so this is quite a rapidly developing area. And this is just something from that Tūāpapa platform that I was talking about. This is Fiji. You can see the areas there where we're really focusing on our work in environmental health and climate change. Again, I've touched on some of these already. And so in the interest of time, I'll keep on moving. And then my final slide is, I've talked very briefly about a whole lot of different challenges, but there are lots of strengths in the system. And I've talked about some of them. There's also quite a lot of commitment from the countries to being part of that regional process. And there's been a lot of improvements made in the last few years, building on efforts over the last couple of decades, really. And so there's a lot more capacity that relates to surveillance now, and there's quite a bit of funding that's come into the Pacific to help with that. And the idea is that we've been trying to work with countries to use the funding that have come into the region for things like COVID to strengthen the broader system in a sustainable way, and that's what we're seeing. But of course, there's still a lot more that has to be done. So thank you very much, Manaka Levu, and just acknowledging three of my colleagues in the office here that help with some of the slides. So back to you.
Wonderful. Thank you so much, Mark. It's really nice to hear what's happening in the Pacific. There's one question, but I will be a bit selfish and ask a question first. Your dengue fever chart was good / concerning, just at that high peak, and then you went into your slides around how you've increased the lab availability on the islands, and obviously the availability of doing the testing is probably going to add a bias into not just dengue, but I'm sure the other communicable diseases and non-communicable diseases. Is that something that you're accounting for?
So in the sense that we get more, like it looks like we've got it like an increase in cases as an artifact of better reporting.
Yeah.
Well, we're conscious of that. And I'm an old public health person from government days and health protection person, so I'm quite conscious of that. But I don't think we're at the point now where, like for dengue, for instance, I don't think the additional laboratory testing is making that much of a difference, because the great majority of the cases that we get reported are from syndromic surveillance. And so and we don't put an enormous amount of emphasis on laboratory testing, except in the early stages when it comes to dengue. So that it's like a confirmation of what's coming out of the syndromic surveillance, but also lets us know what the serotype is.
Right.
So yes, we're conscious of it, and of course we can't overinterpret these trends, but just based on things like burden in the health system, we've got a pretty good sense of how bad an epidemic year is for dengue in the Pacific compared to another. And we're seeing a lot of health impacts and multiple fatalities in Pacific countries with the dengue epidemics this year.
Interesting. Thank you. One further question from Chris. Thanks for the presentation, Mark. It is interesting to hear how all the bits and pieces look as a coherent whole. I would be interested to know what you think are the key future challenges for surveillance in the Pacific, near, mid, and long-term future.
Well, I think a lot of the recent strengthening is because there's been a big focus on strengthening health protection and surveillance and laboratories because of the pandemic. So a lot of that support, the financial support, was tied to that. So there's going to be a challenge both to build on that, but also to maintain the capacity the countries now have. And so the Pacific is not full of people who are experienced and skilled at maintaining medical equipment, for instance. Also, the countries now have to pay for the consumables for a lot of this laboratory capacity, whereas during COVID that was being paid for. So I think there's a planning, a health system financing, and an advocacy challenge, I guess, for everyone working in the Pacific about the need for that continuing investment. Another big challenge is health workforce. And so, the countries do struggle with losing their trained staff. And so, if a country loses the people who know how to use laboratory equipment, then we either have to train them or help the country train new ones, or they have the equipment but they don't have the capacity to use it. So there's those sorts of things. There's also challenges, but also opportunities around IT, and we heard about AI and things like that. I mean, given the hugely dispersed populations in many of the countries. I mean, Kiribati's got a population of 100-odd thousand. It's as wide as Australia. And so what does universal health coverage mean in a country like that? What does effective disease surveillance mean in a country like that? What does good quality service delivery look like in a country like that? And so there's going to be aspects. So a lot of the countries have got better systems in place now for telemedicine. And again, a lot of those investments were made during COVID. But I think there's a lot more that can be done in that space and lots of opportunities. And so it might actually result in better access to some, like for instance, radiology. So a lot of the health facilities have got digital radiology now, but it's still being read by a radiologist somewhere. And so, similar to other parts of the world, there'll be more and more use of AI, I think, for doing those sorts of things. But a lot of it fundamentally is about countries making the best use of the resources they have, but also continuing to think that disease surveillance and health protection trying to improve the health of the population is a big priority for ongoing investment, and being clear that it's fundamental to sustainable development in the Pacific.
Yeah, good answer. Thank you very much. Barry, do you have a question?
No, but Michael has. Michael, how do you work around the different technical capacities, thinking IT, across Pacific countries to ensure reliable disease reporting? It's similar to a question I was going to ask Mark from years ago when I had some involvement. The level of data throughout the countries was pretty vast. I mean, the spectrum. So, and of course, that's the basis of your surveillance systems. So,
yeah, we always try to be very country focused in the work we're doing. We try to actively avoid prescribing a single solution to every country's context, and so we need to work with the country on what are the possibilities in that country, what's the capacities and the systems in each individual country that we can work with them on strengthening, and so we've got some, for instance, I make less use of data that come out of the notifiable disease systems of the countries than I do of the data that comes out of the syndromic surveillance and the hospital-based surveillance systems. So, I mean, I didn't even really mention the notifiable disease systems very much in my slides, because that's where you see an enormous amount of variation, and you see, I think, very much as the tip of the iceberg of cases that are getting reported. But whereas the syndromic surveillance stuff seems to be working pretty well across the different countries. So I think it's also about how do you make the best use of the data that you have. And it's also about, looking at data from other places, like I mentioned about the data on dengue from New Zealand. And so we also do try to do that. The other thing that can get in the way in a lot of countries, and I touched on one of the slides, one of the challenges is that where countries have got digitalized systems, either they're running a system in parallel, and so at the service delivery end, it's data entry on paper. Then the bits of paper go to the district office and hope someone in the district office gets all the bits of paper out of the box under their desk and puts them into the system. Or there's many different information systems that are being used in the same health sector, all often funded by different donors with the best will in the world, that they get a consultant in to build a bespoke system. And so then the systems don't talk to each other. And so a lot of it is more strategic about trying to help countries unify their health information systems, as well as we do a bit of advocacy with partners about not accidentally making the system worse by building additional bespoke systems. And those conversations continue.
Thank you.
Thank you very much, Mark. Well, I think that's
There's one other question, Tim.
sorry. Should have asked it last. Can you mention a few disease names which fall under the neglected transmissible disease group?
Like trachoma, lymphatic filariasis, like all worms and things like that. Dengue is also an NTD. Scabies is also an NTD, but we tend to deal with them in a different way. But the NTDs that I was really talking about in terms of that surveillance is more around the parasitic infections. And there's historically a very high burden of those in the Pacific, particularly things like lymphatic filariasis. There's huge amounts of lymphatic filariasis in the Pacific. There's a lot of trachoma in some of the Pacific Island countries, but not all. But it's those sorts of infections.
Yeah. Thanks, Mark. And I think the WHO website has a pretty good page discussing those, isn't there? Yeah. Well, thank you very much again, Mark. That was an absolutely fascinating presentation and a nice end to our morning's session. We will now go into discussion in Mentimeter, whilst people can go grab a bite to eat or a cup of coffee, a cup of tea. And then our next presentation is going to start at about 12:22, I think. Is that right, Patrick?
That's about right. We can be very, very slightly flexible with the time, but we do have 10-15 minutes if people want to step away, grab some of a brew or a snack, and come back. This Menti session will be running all day. There are 4 little slides to work through, of which you can now see the first, all broadly themed around AI, and we can run through them over the next 10-15 minutes if the chair is willing.
Of course, yeah. Mark, you might as well hang around and help contribute to some of the answers if you want to. There are pretty good questions, Patrick. And then, the first one, how confident do you feel the public service agencies are prepared to use AI responsibly? Good question, Pedro. What defines responsibly?
Oh, I didn't think this far ahead. But if you'll give me just a moment, I will show everyone everything else that is in an offer so they have an idea of what we're going to ask them. So there's this slide. The next question will be a very short answer section where they can put in their own thoughts about the kinds of support or guidance that they would find useful for getting AI into their own work. Then we have some of our good old-fashioned word clouds, one about things they will find exciting about AI, and one about things they will find concerning about AI. So we've got some good meat for the discussion. I will roll back to the start so we can see people's initial responses starting to come in, and then we can move through at our own pace.
Thanks, Patrick. Yep, I think they're very good and pertinent questions for the theme of the morning session. Yeah, should we be slightly concerned about that public service agencies might not be using AI responsibly? Just kind of.
One of the questions that I had, which we addressed before, is that there is a perception that AI is the answer to everything. And I think that both Shaun and Kenyon both clearly said it's a collaboration between AI and the human. And it still concerns me a lot that when you mention AI, sure, there's going to be workforce issues. We know that. But somebody said to me recently, who signs the piece of paper at the end? Who takes responsibility? And it's very unlikely you'll be able to say that ChatGPT wrote this paper, Minister. And I mean, sure, look, Mark, you couldn't turn around and say your surveillance was generated by, ChatGPT, and therefore I take no responsibility. At the end of the day, the buck stops with you. And I think that is an issue that doesn't seem to be addressed. We've got this wonderful tool and it can do great things, but somebody actually has to take responsibility for doing something. And I don't think that's the bit that actually I haven't heard there's a lot of discussion about. I don't know what anybody else around at the moment on this call. I think that's a critical thing, particularly for us in surveillance. It'd be very easy, I think, for some of the work, so that Mark's demonstrated about surveillance, to be generated by AI. But again, it comes back to the specialists have got to be able to interpret what's coming up. And I think that's the bit I think is lacking at the moment. We don't have enough capacity or capability in that interpretation of what AI is generating. We've still got the...
Yeah, thanks, Barry. And I think Kenyon's presentation sort of touched on that briefly. And I wish we had a bit more time for questions, because I had one around, because he used the word orchestrator. I was a bit confused whether that was a human or could it be AI orchestrating its own questions and use of the agents. I could see it happening both. And then you go into the whole idea of who's policing the AI, who's checking to make sure that it's asking appropriate questions.
Well, speaking of the AI asking the right questions, allow me to deploy the power of artificial intelligence to summarize some of this a bit.
Nice. Good segue, Pedro. So what kind of support or guidance would help you feel more comfortable incorporating AI in your work? Yeah, ethics is always going to be a big question, isn't it?
Mark, what's the Pacific's view of AI? I mean, you've got a number of other challenges and you're still there. I mean, it's easy to embrace it. The implications.
I think the great majority of people working in the health systems in the Pacific are more focused on, wouldn't it be nice if they could access digital resources more broadly? It's only, I mean, there's connectivity is still an issue in a lot of countries, although confidential, well-known billionaires are greatly improving connectivity in the Pacific these days. That's actually already making quite a bit of difference. But I think AI, it's early days, I think, in the Pacific, and I suspect it's not actually very front of mind.
Are there any people that are on the call that want to enter the discussion? I mean, we have that capability.
Yes, if you have anything you'd like to add, do please use the raise hand button so that I know you've got something to say, and then I can give you permission to unmute yourself.
Rooshan.
To iPhone KC, you are now clear to talk.
Oh, hi. This is Kenyon again. I had switched to my phone. But I spent a lot of time working on responsible AI issues. And so some of the conversation earlier, I mean, some of the ways we think about it principally is the AI acting in a fair way? Meaning that are its predictions treating different subgroups equally, and especially as it relates to the provisioning of resources or other things that might impact health and wellness. So, I mean, as part of that, have monitoring paradigms where you understand the performance of the algorithm in terms of accuracy for different groups, not only just accuracy, but looking at things like error rates for different groups. And then if you're seeing that the AI is treating different groups differently, then using different algorithmic techniques to try to balance that, right? But part of it is, monitoring and understanding what are the right metrics to measure around the AI, and that's one of them. There's also privacy factors into the responsible AI discussion in terms of not disclosing individuals, providing trust in the AI, right? So I think there's, as we try to get public health practitioners, others sort of more comfortable with AI, it's being transparent about the use of AI, so having it in place, those are a few of the ways that we think about responsible AI.
Thanks, Kenyon. Moving on now, in one word, what excites you about most about AI and public health intelligence? Yeah, efficiency, time saving, working smarter, not harder. Patrick? Focus.
So I can't. Actually, I can. Go AI.
Time saving, speed, potential. Nice.
One of the things I think AI, the advantage I see with AI is that it frees people up from, if you like, the drudgery of doing the analysis and all that sort of stuff. It actually enables us as humans to take that, many of us have slaved over spreadsheets and calculating rates and stuff, to actually move to the interpretation and asking the so what question. And I think that, to me, is a huge advantage, that AI can actually complement some of the legwork that many of us have had to do in the past, but add to it as well. So we can work collaboratively with the tools that we actually have available.
There's a question here from Srinivas, so I will throw open to the floor. The question is AI culturally appropriate for all groups, including some private health conditions like HIV?
Yes, I think it depends on how you use the output, right? What's the intended purpose?
Well, I imagine there's also an element of how are you safeguarding the input to the program.
That was something that Shaun addressed. There was a question, similar question to him, about does the use of this, what's the ethics of actually using AI for the particular ethnic groups or whatever. I think that was an issue. And I think comes back to data sovereignty, doesn't it? Who owns what? And who can do whatever it is with it? Because he in particular is dealing with a huge database. But didn't he say that people signed off consent to use it? Did I hear that?
Yeah, and he said there was only, I think, 14 people that wanted to opt out.
Yes.
Yeah, and I was particularly jealous about this, the large scale amount of data that they use, and trying to compare it to here in New Zealand, where I see that possibly being a bit of a limitation, and that we can't really access sometimes the information that we want to, due to those strong ethic and restrictions that we have to operate within using personal data. But it's also probably a safeguard as well.
Go, Kenyon.
Your comment makes me curious. Are you all beginning to use privacy preserving record linkage to overcome some of those limitations with the privacy regulations, but still enable the training and use of models on data?
This is a good question that I cannot answer. Maybe someone listening in can answer.
Yes, if you are getting sick of the sound of our voices, you are free to raise your hand and chip in yourself at any time.
Yeah, it's becoming more. You're seeing it more frequently with the federal health agencies today, with vendors that'll allow for hashing and tokenization of the sensitive attributes of the data, and then allow for the combination of that data with other tokenized data, which helps overcome some of those challenges. Shaun Grannis was on the call earlier. He's one of the folks.
Thanks, Kenyon. And further to that, is there like an independent watch group that audits how AI data is being used in healthcare over in Maryland?
Yes and no. The Office of National Coordinator for Health IT, which is now the Assistant Secretary for something. But anyway, they do have some new AI regulations for certifying which products can be used in healthcare that get reimbursed by federal payers, CMS. So some of those regulations are starting to roll out. They seem to be leaning towards use of a group called CHAI. It's a CHAI. It's the Coalition for Health AI. It's an industry-led coalition that's putting in place standards for the use of AI in health that their member organizations and others that want to get certified and listed here too. And then doing things like putting AI model cards along with one's products certification. So that's going on. NIST, which is the National Institute for Standards and Technology, has an AI risk management framework that's also voluntary, but many organizations are adapting that to manage AI risk.
Yeah, something to watch out for, I'm sure. With that, Patrick.
Pardon me, I think we do have one last question we can afford to answer, and fittingly, it is from an anonymous attendee. And they ask, in terms of the use of data, does it depend whether or not that data is personally identifiable? If you have lots of data that's anonymized, surely that's useful for looking at risks, trends, interventions, etc., i.e. you don't need to know who they are.
If I was AI, that's the type of question that I would ask Patrick. Yeah.
Well, I don't think you need to know who they are, but I think that people need to know what you're using the data for. I think that's the critical thing about it. And certainly in New Zealand with the IDI, that's a lot of emphasis on the security of the data that's in there. So you can't actually do that very thing. So I think if people allow their data to be used, they need to know what it's being used for. I think that's an ethical question on that one.
And it has to be complete, doesn't it? I mean, you need to make sure that you've appropriately got things like age grouping rights and ethnicity and other social determinants. Yeah.
I mean, Kenyon, are you still there? Oh, maybe not.
Yes, I'm still here. I'm just in the car at this point.
Okay. One of the things that I think is fundamental to what you're doing is the quality of the data you're starting with. For using your analytical tools after that. Is that, I mean, if you've got the data that you've got in that network, is that something that you have control over the data that, control over the quality of the data?
Yes and no. I mean, don't have control over the source quality in many instances, but have access to tools that can help measure quality. Like, for example, with AI, label data can be very important. So we use techniques to look at the sort of inter-labeling consistency of data to see how well suited it is for AI training, for example. Data from different groups also sometimes has fragmented metadata. So starting to use different AI methods to enrich data further through metadata hydration, using AI to try and improve the quality. And then for some programs in health, we do put in place automated data quality checking tools for things like plausibility, performance, completeness, those standard quality metrics, and then can run those. And then ultimately, if we're building algorithms, have the data that is passive quality checks, the data that's being used.
Right.
Thank you.
Nice. Well, with no further questions, Patrick, thank you very much, Barry, for chairing this morning session, and huge thanks to Patrick for facilitating not only this session, but the sessions for the rest of the conference. And I shall hand over to Tūāpapa.
Patrick's the man under the hood, he says. He makes it run.
He does.
Thanks, Tim. Kia ora koutou, ko David Thomas, tōku ingoa, and a very warm welcome to this afternoon's session. I'm delighted to be sharing the session today. This morning we saw many examples of AI internationally, and this afternoon we brought you a diverse group of speakers to working in AI in Aotearoa. So there is no doubt from our conversations and what we see that AI is going to shape our work now and in the future. So without further ado, let's get started. Our first speaker this afternoon is Dr. Vithya Yogarajan. She is a researcher at the Division of Health at the University of Waikato, and her research focuses on bias in language models. She has almost a decade of experience working in the New Zealand health sector and several years of teaching tertiary students. Welcome, Vithya. Over to you.
Hi, I'm just going to share, I guess. Probably works. Does that look right? Okay, cool. Hi guys, I'm Kiara. I'm really sorry. I've been dealing with a cold, so I might not sound as clear as I wish I could have. And thank you for the introduction. Let's I'll just quickly, quick introduction of myself. So I've got a very mixed background. So I've got a PhD in computer science and AI, but I've also worked in the health sector for a bit, and I was part of the expert panel that was looking at AI in healthcare for the Office of Prime Minister's Chief Science Advisory Group. I've got twin boys, and I'm originally from Sri Lanka. In terms of my current research and AI and healthcare, obviously, as was mentioned before, my main research also focuses on bias in large language models, especially ChatGPT and similar kind of models. But I have currently been working on cancer outcomes for lung cancer patients with Ross Lorenzen, and I've got a HRC-funded project that's on AI evaluation framework. I'm looking at predicting severity in acute pancreatitis and also, GP healthcare harms with University of Otago. So I've sort of got my self in lots of different projects, but that kind of helps me understand the overall picture of what's happening in New Zealand as well in some ways. I figured I'll just quickly go over, I was trying to decide what to put together for this because 15 minutes isn't a lot to try and cover everything. So just a quick taster. So as I said, the government was trying to, they were trying to have some regulations in place, and there was a panel that worked together. So some of the outcomes was that they had some goals in place and recommendations as well. Sorry, for some reason, I'm struggling to see my own screen, which is not very good. Okay, but the examples of recommendations, obviously the National Data Platform, and this goes back to the issue that you guys were discussing earlier about data sovereignty and who has control over it, and at the same time, being able to have it in one place and safeguard it means there's less likelihood of it being misused, or we've had a lot of data breach issues that's happened in the past in New Zealand as well. So yes, we want to implement AI, but at the same time, we want to be implementing it safely. And the other example of recommendation, of course, is the administrative load, which I think it's quite known, especially in New Zealand with the last few years where we've had a lot of difficulties with shortage of workers as well. I think this probably has been already covered, but I wasn't sure what sort of audience I'm looking at. But a lot of people get excited by ChatGPT, and a lot of people get afraid by ChatGPT. But AI as a whole is quite a lot bigger than just ChatGPT, even though ChatGPT kind of became this big key excitement for people. And so that's quite important to note, because it's sort of within machine learning, within deep learning, and there's been people working on this area forever. It's not something that just happened overnight in the last 2 years. I was trying to put together some examples, and after listening to a couple of presentations earlier, I sort of realized that some of these has sort of been mentioned as well. But we've had different ways in which AI has been used across New Zealand, well, across the world. But in New Zealand, I think COVID was one of the key ones where there was some ways in which AI was used to help, and that was quite good to see. Now, going back to this trust issue, and this is something very important for me because, as I said, I do also look at the biases in large language models, and I realize how difficult it can be. But we have to be able to use it such that the organization is transparent and responsible, and organization has to be accountable for it as well. And I think a simple example of accountability that I find interesting is that a lot of GPs use transcribers, AI transcribers, to turn their notes into written documents, and then it's put away, and that becomes the patient's history. Not many people actually read it, go back and check whether the transcribed data has been done right, whether there's been any bias included in the way that transcription happened. It's not necessarily always correct. So who is accountable? Is the GP accountable for the patient history being changed because of the fact that he decided to use an AI tool to record the session? It's kind of a bit of a question that has come up a lot. I don't think there's an answer to it, but it's interesting how many people don't realize how much of AI is used in a day-to-day, and assume AI is sort of further away, whereas it's sort of part and parcel of our day-to-day life. Phones are AI. You do a Google search, and all of a sudden your entire social media is filled with all of the search that you did. So it's there. And we do need to be able to explain the system that we are using. We do need it to be interpretable as well. So in terms of bias, we know that AI comes with a bias because the data that it is trained is historically biased anyway. So the social biases that has been around will reflect. But the problem with it is that people aren't sure how much it will reflect and whether that means it's being unfair towards a specific group. There has been a lot of research examples where it does show that there is a certain unfairness towards a specific group. But the problem with it, of course, is that a lot of these works are done around the American white and black sort of demographic setting, and New Zealand is quite different. And we've got a smaller but much more diverse group of people. So whether it's going to be more harmful, the inequalities that Maori face, is it going to be more worse because the AI was used, is a question that rigorously a lot of people are trying to answer, and a lot of work is being done on that as well. Now, I do think this is just one possible recommendation, of course, but using it does require continuous monitoring, and you do need human in the loop. You do need quality improvement, and risk predictions are needed to be able to use AI. So you can't just say, okay, this tool works, so I'm going to use it, and then forget that you're using a tool. It has to be monitored the same way a healthcare professional has to go back and get checked. They have to keep improving themselves. So it's the same thing with AI. You have to keep improving it. Sort of try to put a framework together. This is just one possible example. The thing here is, of course, is that your data is biased. So we do need to deal with debiasing it at the data level. But then you also need it to be as real as possible. Debiasing shouldn't end up hurting the opposite side. So if we take it too far, it will end up hurting the predominant group there. The other group will get hurt because of it. So you have to be careful there. And then, of course, algorithms that are selected has to be also very carefully selected. It's not just about accurate algorithms, but it's also about fair algorithms that are collected. And you need a feedback loop. So you do need to be able to say, okay, if I've got a prediction from AI, can I explain it? Does the patients get harmed by it, or are they going to get benefit by it? And would a clinician or an expert can explain the outcome in a way that makes sense? And so that sort of expert level is important in terms of deciding where you use AI and how you incorporate it. And of course, with New Zealand, we need to be careful that the data sovereignty issues are also handled right. Okay, I always find that spending a bit of time on this slide is quite exciting, because this is all these issues that people have thought about. Professional liability. This is a discussion that was happening when I was joining here. Who is liable for it? Who takes the responsibility of it? And I'm guessing that's my time, but couple more minutes is and of course you need to think about what sort of ethical considerations we've had, privacy issues that comes with it. Having said all of that, AI is there. It is very good and it is very productive, and it does improve the workload and performance. So we do have to take a balanced look at it. We can't say, no, I'm going to ignore AI exists, but at the same time, be cautious of it, I guess. That was my last slide, so that's all right. I think I'm okay with time. Thank you, guys. Questions?
Thank you, Vithya. That was an interesting presentation. I think our people in our audience who might be a bit cautious around AI would be glad to have listened to your presentation there. I'm just having a look if we've got any questions in the QA or chat, but we haven't. But I can start us off. You showed us that framework in your presentation, and I was wondering, have you seen aspects of that methods and in practice in Aotearoa?
So I work very closely with the so there's a AI data research group that's led by Robin Whitaker and Rosie Dobson, and so a lot of these ideas do resonate from them as well. So a lot of my projects have been with them as well, and so yes, there is a high emphasis on trying to find ways in which you can implement it and have a continuous and it's an ongoing discussion, and it has been anywhere where it's implemented with some, okay, we've checked it, we've gone through the right pathways and implemented, rather than downloading a software or downloading something off your phone and deciding to use it, I think has been a lot more monitored. So yes, it is happening.
And just a follow-up question around that. Have you seen any examples where AI has been developed with people in the community?
Yes, but there's also, I'm not sure whether, how do I put this without sounding, so there is a lot of work done, but whether that's healthcare related is, it's still happening, I suppose, is probably a better way of saying it. There are a lot of people who are saying that they're trying to contact the community and try and work with it. And in terms of the actual implementation, I don't know any example that is implemented, which has been developed through community in New Zealand, if that makes sense. I do know examples of research level work that's happening, but day-to-day real life use might be something slightly different, and I don't have an example for it. Sorry.
That's all good. Thank you. Peter?
Thank you, Vithya, for that presentation. I enjoyed it. I was interested in your slide around biased, about AI being biased, and I just wonder, how do you think it will deal with those people that don't interact with the health system? Will it be, do you think it'll capture any of those people?
So it should capture. So when the bias issue is not necessarily specified for those people as such, but it's more that because AI is trained already in a data that is capturing only a specific, if you take 100 medical data and you've got only one Maori patient and 99 European patient, the overall model is going to work around being more favorable to a European patient over a Maori patient, and I'm Sri Lankan, and sometimes it doesn't capture that, right? So what we are trying to enforce is that we need to check that that is not the case. So you need to actually try and get some quantitative understanding of the bias that is there before using it, and that's sort of that pre-test audit stage that needs to happen before just randomly picking something and going for it. Because a US based model might not necessarily capture what's happening in New Zealand very well. So I guess that's, and yes, I agree that some people aren't keen on using it at all, but unfortunately, if they've been to a medical professional and the data has been used in some way of modeling it, and like I said, I don't know anything real life that's happening which has used New Zealand data yet, but I know there's a lot of research that's happening around that area. Hopefully that makes some sense.
Yeah, thank you.
Patrick, we've got a couple of QAs. We've got time for that?
Not really. Well, we might squeeze one in very quickly. Michael, I hope your question about bias in AI was sort of addressed by that last answer. So if you don't mind, I will skip over you and go to Srinivas, who wants to know how we can use AI in performance, whether for workforce performance or reporting purposes. Hopefully I've understood that right.
I'm not 100% sure what the question is asking, but I'm assuming they're talking more about I don't know, reporting in terms of like yearly reviews or workforce reviews. I'm guessing that's what they're talking about. And Srinivas, I'm sorry if I got your question wrong, but there are actually a decent amount of software, and I know that Google and Microsoft itself has quite clear, easy, simple solution for it. And this is an area where it's less risky because you're not harming a specific patient, but a summary of your performance is fairly straightforward. And I'm sorry, I'm very skeptical in answering this question because I'm not 100% sure what the question is asking me. Apologies.
Oh, hang on a second.
That's fine. I think that's a good point for us to move on. Thank you, Vithya.
I should have asked, so you can ask that question directly now. You're allowed to speak. I see you had your hand up.
So I think it's a good point for us to move on now. Thank you, Vithya. Can I please ask you to stay online for our discussion at the end of the session with all the other speakers? So moving on to our next speaker, who is Dr. Cheng Jin. CK is a clinician by training and combines data science with healthcare. He is currently the clinical director for Health New Zealand's AI lab. His experience spans predictive modeling, clinical decision support systems, generative AI, and the development of frameworks for responsible AI use in healthcare. Welcome, CK.
Good, everyone. I'll just share my screen. Cool, I think everyone should be able to see that. So, kia ora koutou, ko Cheng Jin toku ingoa. I'm Cheng, but most people just know me as CK. I'm the clinical director at Health New Zealand's AI laboratory. Today, I'd like just to take you through how Health New Zealand is using AI, where we're at, what we've learned, and where we are heading. There's a fair amount of content to cover, and if people have outstanding questions, please feel free to contact me afterwards. So when it comes to defining AI, it's actually something that is quite difficult. It's become a bit of an umbrella term that consists of multiple different types of algorithms or approaches. In Health New Zealand's context, we're using quite a broad definition of AI. It extends from simple algorithms to deep learning, NLP, and generative AI. All these will fall under the scope. So in terms of our work areas, it spans kind of across three main categories. So risk or priority scores, machine vision, and generative AI. Each comes with different levels of maturity, benefits, and challenges, and we'll talk through each area, provide examples of how AI has been used or will be used in Health New Zealand. So I think risk scores, they are quite well known within the healthcare context, and it's not an area that I'll explain kind of in depth. It's an area where we have the skills and expertise to develop and implement such tools. And a good example of this is the COVID triage tool. As Omicron emerged, we needed a way to prioritize care quickly, and this tool was developed to help identify patients at high risk of hospitalization to enable early virtual assessment and, if required, further clinical management. These risk scores involved a large exercise of linking different routinely collected data sources together. Since the information is routinely collected, the risk score could be automated, triggering when a new COVID case was reported. We displayed the results to the end users via a dashboard with the risk scores highlighted in red and the factors that contributed to the risk scores being displayed beside it. I think the algorithm itself was used by the COVID care in community teams across Auckland during the Omicron outbreak to prioritize initial virtual assessments. In terms of the results, they are presented in the graph below. The bars represent the number of infected individuals in each risk band and the number of patients who were subsequently admitted to hospital. Just want to note that the y-axis has been scaled and the line demonstrates the percentage admitted within each risk band. Individuals with a risk score of 0.2 or 20% or more were considered to be high risk and prioritized first for virtual assessment. Medium risk, individuals with risk between 0.1 and 0.2 contacted when capacity allowed. Individuals with less than 0.1 risk score were left uncontacted. This approach provided a manageable process for the community teams, and based on their feedback, they felt pretty well controlled during the surge of new cases. However, despite the usefulness, clinical risk scores, they do come with some important limitations that we need to be aware of. So first is generalizability. Many of these models will be developed using data from specific populations and may not perform well when applied to a different population or healthcare system. Second is model drift. Over time, as clinical practices and population trends evolve, performance of the risk score can degrade unless it's regularly updated. Third is that there are ethical implications, especially when these risk scores are used to determine access to care or interventions. If the model isn't accurate, it could have serious consequences. Finally, it's transparency. Many models, particularly more complex ones, function as a black box, making it difficult for clinicians to trust or understand the output. These limitations reinforce that risk scores shouldn't be used in isolation. They must be properly understood and validated if required within a clinical context. Second area of focus is machine vision. It's an area where we are seeing more commercial AI tools starting to be tested or implemented. Retinal screening has been an area of focus for us, as it was one of the first fully automated AI use cases gaining FDA approval. Within New Zealand, our screening rates are poor. Across the Auckland region, screening rates is around 50% when a target is 90%. This is driven by a number of reasons. First, it's the limited number of screening locations and their hours of operation. Staff training and retention is difficult. There are no formal qualifications, and training occurs on the job and takes about 3 months for an individual to know what is normal and what is abnormal. The process can be paper-based, so a piece of paper will go through 3 different inbox trays before a final grade can be generated. And this results in quite a long process for the individual to get their final result, leading to disengagement by that time. So AI has been viewed as a potential solution. The diagram shows the current screening process on the left-hand side. The middle and right shows the 2 ways of AI being implemented into workflow. The one to the right demonstrates a fully autonomous system where AI is responsible for generating the final grade and sending a referral if required. However, in New Zealand's context, given the shortage of ophthalmologists, AI was used in this way would have generated too many false positives and created a bottleneck further down the treatment pathway. Instead, we are proposing to use AI as described in the middle diagram. AI will act as a primary grader, responsible for determining what is normal and what is abnormal. Normal images will go back into the screening pool, abnormal images will go to human for further grading. This way, we can maintain current accuracy whilst reducing their grading requirements by around 50%. In terms of introducing AI into the community-led screening process, 2 pieces of work have been occurring. First was the development of a new model of care, which introduced screening cameras into a community setting to test how the workflow can be set up. On top of that, we are also testing 2 AIs against historical images, as well as images acquired during the model of care. The results are in the process of being published, but I can share some of the initial challenges that we encountered during the process. First, the existing legacy IT systems were a challenge. Often think of them as a black hole. Something goes in, but cannot come back out. On top of that, the existing systems couldn't accommodate AI, and a new image capture system was required. Second, we did encounter accuracy issues using historical grades. Both humans and AIs are not perfect and will make mistakes. However, when we reviewed the discrepancies, most of the errors were related to humans. Third, we did have quite a high rate of photo failures, around 15%. Whether this was due to the AI or poor historical images, I am uncertain. However, if implemented, the high rates of photo failure will have an issue. Lastly, we did encounter a lot of initial workforce resistance to change. You'll never address all the concerns, but there's always a new concern. All these limitations highlight that implementing AI is actually not that easy. In terms of other areas of machine vision, radiology is the next area of focus for us. Many commercial AI tools are available and are being implemented into clinical settings internationally. The use of these tools will extend beyond just as a diagnostic aid, but can be used to reorder the reporting work list. So exams with critical findings will get pushed to the top of the reporting work list. Normal exams can be deprioritized. AI could also be used as an initial screening tool to reduce outsourcing, particularly during after hours. Exams which are deemed normal don't have to be outsourced for urgent reporting and can be left for reporting the next day in-house, or lengthening the reporting turnaround times, which will have a lower cost. Chest X-rays, it's not only area of focus for radiology, but work is also being planned for AI and fracture detection and breast screening as well. I think the last area of focus is going to be around generative AI. This isn't something I want to discuss too much, but AI scribes are becoming an established use case for generative AI within healthcare. With these tools, they function by turning a patient-clinician conversation into a transcript, and it's subsequently summarized by a large language model. We're seeing these types of tools being increasingly used within Health New Zealand. However, the main thing I kind of want to get across is that AI scribes, it is just one use case for Gen AI, and it is relatively straightforward. Other use cases are being explored and need to be evaluated. We're in the process of testing whether language models could help write discharge documentations or be used to summarize a patient record. Retrieval augmented generation is another area for Gen AI that we are testing. This architecture can be used to develop customized chatbots, customized search functions, and they're actually relatively straightforward to develop. Just want to make one final statement on Gen AI, and it's around language models and Gen AI platforms. So language models, things like GPT-4o, are the foundation for these platforms, so things like ChatGPT. Language models can be accessed by a commercial license, which is safe from a privacy perspective. Gen AI platforms are not. All your chat history gets retained. So just want to finish by providing my view on the future direction of AI in Health New Zealand. For risk and priority scores, these are well-established technology with potentially quite large benefits. The main challenge is identifying a good use case. There's little value in generating a risk score if you cannot provide an intervention to reduce that risk. I think this point is often missed when I come across these projects. For computer vision, this is a relatively new technology for Health New Zealand, but it is not new internationally. Off-the-shelf solutions are becoming more common with good evidence behind them, and we are seeing more of these tools being introduced into clinical practice. The next challenge will be to establish a process to monitor these tools long term. Large language models are a relatively new technology, and the use cases are still being identified. Utilizing the technology for specific use cases will require specialized expertise, but this barrier is reducing. And in the near future, I can see these tools being developed for quite specific use cases. So kia ora everyone, I think it's the end of the talk. I think we have a fair amount of time for any questions.
Thank you, CK. It's great to see some examples of AI in New Zealand. We've got a couple of questions at the minute. In the middle diagram, the ones that AI said is not referable will be looked at in a year's time, I think. Is there any sampling of these screening to see how accurate they are rather than assuming they are as good as what's done by human?
So I think, yeah, the issue of the ground truth, it is an area that we are trying to address. So as part of future work, we will try to set up a process where we can try to establish better ground truths for the results. Hopefully that will provide us a more accurate understanding of the AI. In terms of sampling for screening, the approach that we've taken is essentially just try to run things historically, so take a 6-month, 1-year cohort of individuals, analyze them by AI, but I do see the value in trying to sample specific grades just to try to have an equal prevalence within the data set.
Thanks. Pardon me. Thanks, CK. We've got another question from Carolyn Shaw. Thanks, CK. Awesome talk. Are there regulatory issues around using AI in healthcare? For example, medical council requiring healthcare workers to be responsible for any scribed notes, meaning they need to be double-handled.
So I think the issue of AI and regulation specifically for healthcare, it is a global challenge. Within New Zealand, I don't think we will have any kind of AI regulations in the near future. I think the main way that AI is going to be captured is through the update to the Medicines Act. Apologies if the terminology isn't correct, but there is regulation coming. But until then, I think we'll be at least a couple of years away, pretty much operating in a grey zone where there's little to no regulation. In an international sphere, when it comes to these AI scribes, they've been viewed as administrative tools. So there's no FDA, there's no form of regulations. You do see that there, out of the NHS, there is more push for these tools to be regulated. So I think maybe in the next couple of years, we will see more regulations around it too.
Thank you, Caroline. Another question from Michael. What are some of the barriers or pressures you faced when trying to implement AI at Health New Zealand?
Where do you even start? There's a fair amount. I think with the restructures, it's been somewhat difficult. However, I think we are getting to a point where there is more clarity. The kind of fragmentation of the electronic systems or the different systems, that is a difficult part as well. Trying to link everything together, somewhat difficult. And then lastly, it's always funding. If you can't actually get funding to implement AI, you can't really use AI, can you?
Thanks for that. I know you were focusing on clinical practice there, but just a question for, I guess, for a large part of our audience is there much thought being given to the use of AI in Health New Zealand for analytical purposes?
I think most definitely. I think the talk's been framed more through that clinical lens, but there's definitely work happening in the kind of back office administrative side of things. We are seeing generative AI tools being kind of built into these cloud platforms, so things like Snowflake, Databricks, they all have generative AI's kind of capabilities being built in. Pretty easy to essentially write text for it to generate code. So trying to start a project up has become incredibly easy and quick. We do have access to commercial licenses to OpenAI models. We are trying to develop specific use cases, mainly just through kind of like RAG models to search for kind of protocols, guidelines, information. Otherwise, it's building a chatbot. But so yeah, some of the non-clinical use cases.
So there's a process in Health New Zealand to go through if people have ideas?
Yeah, so reach out to the NAAG group, so the National AI and Algorithm Expert Advisory Group. There'll be a good contact point to either talk about your ideas or try to put you into contact with a person who might be able to help you.
Okay, thanks, CK. A couple more questions. In Te Whatuora, do we have an AI tool in Māori language, or is it only in English?
Tricky question. I think there are language models that's being developed within New Zealand that's quite specific to Māori language. However, most of the language models we use are from commercial companies, so things like OpenAI. They do report some to their understanding, but its full capabilities, I think it will be limited. Trying to influence whatever OpenAI does, I think it's pretty much impossible for Health New Zealand.
Interesting. Next question. You mentioned in your presentation around workforce resistance, and this a question from Michael around concerns or resistance raised by clinicians when AI tools have been introduced.
Yes, there is. I think just trying to say what is the best way to discuss this. I think you do get resistance to change, and trying to figure out the exact reasons for the resistance can be quite difficult.
Right. So, what kind of strategies have you employed to sort of address concerns?
I think you can try to understand the concerns that the clinicians are coming from. You can address as much as you can, but there will be a point where we can't address it any further. So I think escalating it above is probably the best approach there.
Okay, thank you, CK. I think our time's up.
Oh.
Can I ask you to stay on for the end of the session for our discussion?
Sure thing, most definitely.
Thank you. So is our next speaker online, Patrick?
They certainly are.
Awesome. So our next speaker is Pedro Ramirez. Pedro works in the Office of the Government Chief Digital Officer, Currently, he's at the forefront of the public service AI work program, and he brings over 2 decades of senior leadership experience in this area. Welcome, Pedro.
Kia ora. Thank you. Just checking first, tech that is working. Can you hear me and can you see me?
Yes.
Brilliant. So first of all, thank you everyone for the invitation. Really pleased to be with all you today. And I was just looking through the agenda, and I mean, I don't know how many countries do you have across the different agenda, but it was just lovely to see this type of events actually reaching out and just using technology to engage in the wider context, multiple jurisdictions. So really excited to be with all of you here. My name is Pedro Ramirez, and I work for the function of the New Zealand Government Chief Digital Office. Just kind of similar function in other jurisdictions, basically leads digital across the public service and in some initiatives across the public sector. And the acronym we use is GCDO, Government Chief Digital Office. So the GCDO is who leads also artificial intelligence across the public service and sector. And I mean, my key responsibility is to just progress our program of work. And if I'm correct, just checking here, we have 20 minutes, probably I already consumed 2, so we might have 18 minutes. Is that correct?
Spot on. Good timing.
Brilliant. Okay, so what I will, and that covers Q&A, or do we need time for Q&A to be considered?
That will include Q&A time.
Brilliant. So look, I think in this set of sessions, what we get most out of it is really the Q&A and answering those questions. So what I will attempt to do is in the next 8 minutes, take you through the high-level view of our program of work in the New Zealand government, and then just leave the rest of the time to have 10 minutes of Q&As. And if, I mean, we don't have enough questions, then can deep dive into any of the topics. But if I start, I will only share a couple of slides. I don't want to make this a full presentation mode, more of a conversation. So, but if I start, I mean, really important authorizing environment for us is our minister. And I'm sharing my screen right now. Patrick, do you mind if you can let me know if you can see it?
Yeah, we've got you.
Brilliant. Okay, so I mean, really first slide is a clear direction from government is to be responsive, accessible, and really address real needs. And second one is just really use and embrace artificial intelligence. That is the message from digitalizing government minister, Judith Collins. And very good authorizing environment for us is that the Minister for Digitalizing Government is also the Minister for Public Service as a whole. So that is, sends a very strong signal on, I mean, digitalizing government, including artificial intelligence at the forefront of the agenda. And the way we use the diagram I use to explain our program of work is really, our approach is to enable in a safe and responsible way artificial intelligence. And even though it has in the middle artificial intelligence, the important part for us to talk about here is that this is just the approach of any emerging technology. When we talk about emerging technology, we need to ensure that we enable it across the public service. We need to ensure that it's safe and responsible for the public service to be used. And what I will attempt is to then give you kind of a quick view of the different areas and programs of work that we have in each of these quadrants. So I will stop sharing there and just take you through some of the programs of work that we have. So in terms of enabling, we have deployed a comprehensive program of work across the public service. We have deployed artificial intelligence master classes for chief executives and deputy chief executives. At the same time that we have a comprehensive program of work of AI foundational training for the public service in general. This is hosted in the Learning Development Center out of the Public Service Commission, and anyone could access the content. The content is just one part of the program. The content is only the e-learning part, but it's a hybrid model where we actually have online sessions face-to-face with the participants of the program of work. We have just finished our first pilot, and we're going to be finishing the full initiative this month. We also have set up an AI expert advisory panel to advise the public service and GCDO in its capacity as the lead of AI, and you can find this information in our main website, which is digitalgovt.nz. Who's in the panel? What is the objective? We had also deployed a very extensive artificial intelligence community practice. So we have around 90 organizations of the public service joining into the community practice. Is a way for us, the way we frame the community practice around share, connect, and learn. And Share is an organization comes and shares their entire artificial intelligence program of work. Connect is about a problem that we are all facing, and we come together and in real time using AI start to summarize what's sort of the problem, how are we solving it from different organizations, and then enable those organizations to start connecting in sort of those key topics. And finally, Share is about we share full deployment of artificial intelligence solution. What was the main outcome, the benefits, challenges, lessons learned, and we do this every month, and then we have deep dives for specific topics. In terms of SAFE, we have now an artificial intelligence strategy for New Zealand that was launched. This is an artificial intelligence for the country, and it was developed by the Minister of Business, Innovation and Employment that sets up the wider agenda. And of course, there is a small part for the public service, and you can read that sort of one pager in terms of everything that I just basically have been saying. We have an artificial intelligence framework also publicly available that states our vision, our objectives, our work programs, our context, and our pillars of the program of work. And we are also deploying an artificial intelligence assurance model that will enable public service organizations to ensure when they are deploying and using artificial intelligence, they assure the right dimensions and the right controls are in place. And finally, in terms of responsible for us, we have responsible AI guidance. This is publicly available and basically is based on our key principles for deploying artificial intelligence. Important to note is that both our principles are based on the OECD principles. In 2024, Cabinet approved that New Zealand will adopt the artificial intelligence principles from the OECD. And it's basically based on the principles, clear examples, and clear guidance about the areas and what we could do, very practical for practitioners. And the last one is we are working with a group that is called the Data EWI Leaders Group. This group has an agreement with the GCDO, and they encompass multiple EWIs, and we're working with them very closely and reading the last stages of basically deploying an artificial intelligence toolbox Maori perspective that will bring the considerations when deploying artificial intelligence from a Maori perspective. And obviously we have a big coordination with multiple countries around multiple working groups. So I think if I started 10 minutes, there you go. So I promised 10 minutes of me talking, and really keen to just now, happy to deep dive into any of the questions, or if there's a gap there that you identify, happy to let you know if there's some program of work that I was just not able to cover because of the time. But I will stop there, Patrick, and yeah, happy to take any questions.
Thank you, Pedro. That was a whirlwind. There is plenty of going on in your office, which our audience would find a lot of new knowledge there that you have shared. I'll have a look if we've got any online questions.
Yeah.
None at the minute, so I will kick off. You mentioned around the training aspects and the pilots that you developed. What's the intention around making that more accessible? You know, what are the next steps?
Yeah, so the content is already accessible in terms of anyone could access it, right? I mean, you can access it right now. The entire content is basically 5 modules, 5 weeks, 5 modules, different topics. It takes you from what is AI to safe, responsible AI to how do you need to think when you are deploying a project. It's very targeting learning objectives about deploying a project, right? And ensuring that the right things are taken into consideration. Next step for us is just to roll out to more organizations, right? We have 50, I mean, depends on the count, right? But it's around 51 organizations in the public service. We cover in this first pilot 10, and the idea is to just roll it out to all organizations. So hopefully by the end of the year, we have covered a bigger percentage, if it's not all the organizations in the public service. And the second, I mean, there's another part to your question. Second part is just to ensure that there's also a full e-learning program, right? This is a hybrid one, right? Even though the e-learning component is publicly available, there's still a classroom approach, right? So we also want to work on a full e-learning program of work. And in terms of the artificial intelligence sort of for chief executives and the deputy chief executive, sort of that kind of tier 1, tier 2. The idea is we have covered in this first pilot 75% of the organizations. The idea is to just roll it out so we are able to cover those sort of 2 tiers comprehensively by the end of the year. Did I answer your question?
Yeah, no, that more than answered it. Thank you. Barry.
Pedro, thank you for that enlightening presentation. And I think you might have just touched on it, but you're producing a framework, public service framework, and of course, there's a whole bunch of public service departments. Is this the framework for each of them to work so they don't go off and do their own thing? Is that the intention?
Absolutely, Barry. So the framework has been already published. We published the framework, I think, at the end of January 2025, and basically it's a mandated framework, right? Public service organization, because GCDO is the lead and has the mandate on AI, is they need to, that's why it went to cabinet in 2024. Public service organizations need to follow that framework. They need to adhere to the principles, to the context, and ensure vision and outcomes, right? I mean, one of the things that we're starting to see, expanding a little bit on that, when artificial intelligence strategies get put in place in some departments, I wouldn't say all departments will have one, but the ones that have one, they come and present that in our artificial intelligence community of practice, and they ensure the alignment, and they talk about the alignment. How did they align it to their own sort of context? If you are a tax department, you have specific environment versus you probably are in kind of law and enforcement. But the short answer is, I took 3 minutes to say, yes, Barry, we expect them and they follow the artificial intelligence public service framework.
Can I ask another question, David?
Yes, go for it, Barry.
What resistance do you get from government departments, Pedro?
Look, I think that the resistance that you would always get, and the topic is artificial intelligence, but it's just the normal resistance, which it comes from a very good point, right? There is always this tension between the uniqueness of a department and how just like normal a department you are, right? And the normal tension is I will say there's no resistance at the highest level, right, of the framework. We're on the framework. Is when you go into the next levels of details, right, that you go, how do I implement this principle in my context if I am in the justice domain versus if I am in the, I don't know, foreign trade domain, right? So I think the way I will describe it is there's no resistance about the framework, or I have not encountered resistance about the framework, because it's principles guided framework. However, once you start to go into the more detail, more than resistance is how do you enable it at that point? And that's why guidance like this responsible AI guidance for the public service and also the AI assurance model are going to help them to navigate that into more sort of detail. But I mean, I would say the normal resistance that you will encounter to any digital all of government policy. I mean, talking to other jurisdictions around the world is just the same one, right? Centralized functions versus decentralized functions, and how do you kind of convey in the interest of the whole with the particular objectives of that domain specific agency. Did I answer your question, Barry?
Yep, thank you. Good.
So Pedro, you know, with the framework and all the sort of guidance that comes along with that, are we, you know, reflecting one of the questions that we have, are we heading down the road of regulation of AI in New Zealand?
Yeah, look, that is a really good question, and I get asked that question quite often. And the way that I get the people frame that question normally, which is a very interesting way to frame it, they ask me, "Are you the European Union that you are going to have an act, or are you are you sort of Estonia that they decided to just go and don't create assurance and just educate the public service, right?" And I mean, the short answers to that one is neither of them, right? So far, 2024 cabinet paper stated that the current regulations that we have in place are sufficient for the advancements in AI at that point. However, in our program of work for 2025, we have a piece of work that is called an AI legislation review, which is going to be looking again around all our legislative settings and ensuring that they're still fit for purpose in terms of what has happened from that review that we did in 2024 and 2025. I mean, no one in this call probably will disagree that the pace is something that is very, very challenging and interesting at the same time in this legislation space, right? But the short answer to your question is, we currently, 2024 cabinet paper made a decision current settings are in place as long as we provide assurance and guidance. And we still have another review to be done this calendar year to ensure that that's still the case.
So it's not anytime soon. Okay, and another question I've got is, you know, as part of the guidance or in terms of the framework, is there any thought around measuring the impact of AI initiatives in public service delivery?
Absolutely.
Public trust as well, tied in with that?
Yeah, look, absolutely. And we have, so there's two parts that I will say. The first one is, when we talk about the topic with our counterparts around the world, and if someone else in this call will disagree, I will be very happy to learn from you. But what we agree when we talk to our counterparts around the world is still very nascent, the measurement in terms of public value, right? Of AI, and we still have quite a lot in the ideation, prototype, proof of concept. And I mean, if you take New Zealand, I mean, in 2024, we only 75% of our efforts were in that stage, right? Pilot, proof of concept. We definitely have moved a long way from last year to now, but still, we're still sort of starting to see. So, I mean, the way I frame it is we have expected benefits, but we do have a sort of simple framework that was one of the most advanced organizations developed that we have shared with the wider public service to how to measure, right? But it's very important to just sort of say that, because I mean, even though probably some of the world media will disagree with my statement now, even though we think that everything is AI right now, AI is still pretty nascent in the Gen AI piece of deployment, right? Already productionized, live, and we're still starting to do that piece of work. And the reason why I mentioned other jurisdictions is because that is one of the key pieces of work that we work across other countries very, very closely in how to measure, and we share quite a lot on that public value and outcomes, benefit realization outcomes out of artificial intelligence.
So how does New Zealand rank against similar countries in maturity of use in AI?
Yeah, well, that is a great question. And we love rankings, right? Humans do, meaning. So look, I mean, the short answer, we are not at the bottom, we're not at the top, we're in the middle. Depends on the survey, right? I mean, vendor-led surveys versus, like, I don't know, global organization surveys will differ. I will leave it there in terms of like the different surveys. I mean, not saying which one is right. What I could tell you though is one of the uniqueness of the New Zealand Public Service is the agility of the pace that we could move, and that just has to do with our size and the way we are just orchestrated as government, right? Other jurisdictions, they have national government, local government, state governments, and probably 3 or 4 layers in between, right? We have the massive advantage in New Zealand that we have a good size, and again, we have the agility of our structure to move at very good pace. So if I think about 2024 and now 2025, that the pace that we move in 1 year has been massive. We move almost from an only pilot proof of concept, 75%, to now we have sort of a 45 to 60%, right? 45 in that stage, and the rest has moved. And that has to do just because, I mean, a lot of also the public service culture in New Zealand. I mean, the other colleagues that are from the public service here will concur with me that it's just, I mean, it's just high level of trust in the public service or public servants, and that just create an environment of agility that is fascinating to watch, especially how work across other 29, 30 jurisdictions. And I find that size, pace, trust in the public service very unique in New Zealand. And I think that is kind of what it moves. But the answer to your question is we rank in the middle.
Thank you. Very encouraging to hear around your thoughts about public trust in our public services. Barry?
I was just going to add, as long as we're ahead of Australia.
Yep.
Oh, good. Just for our next speaker.
Just before we go on, our next speaker, a question from one of our audience was asking what was your website again?
Absolutely. It's www.digital.govt, as in government, .nz, New Zealand. So I will put it on the chat for anyone to access. I will type it now.
Awesome. Thanks, Pedro. And thanks for a, great presentation. And we'll move, if you can hang on for the discussion at the end of the session, we would appreciate that. We'll move on to our next presenter, who is Dr. Sidong Liu. He's a computer scientist and a research fellow at the Australian Institute of Health Innovation at Macquarie University. He established the translational AI for healthcare research stream within this institute at Macquarie. And his work addresses real-world challenges in healthcare AI implementation. Welcome.
Sorry, I'm trying to unmute myself. Can you hear me now?
Yes, we've got you.
Okay, great. Thanks. Thank you very much for the introduction. I'm a senior research fellow from Australian Institute of Health Innovation. And well, I'd like to, just to give a quick overview of our institute before moving to my presentation. So we are a institute focused on health service research, and we have about more than 300 staff members and 60 HDR students. So this is a big institute, and we have multiple research streams within the institute. And the institute is very proudly leading the Australian Alliance for health for artificial intelligence healthcare. Professor Rico Coira founded this alliance in 2008, and now we have more than 150 members within the alliance. So back to, as I mentioned, this is a big organization, and different people are working on different research areas. And I'm currently leading this AI for precision medicine research stream. Well, before that is branded as the translational AI for healthcare. But just then recently, we think this would be a more accurate description of the research we do. At the moment, we have 17 researchers within the team. We have a few lists here. We also have like a few others from overseas, like visiting us at the moment. And myself is a computer scientist by training, and I specialized in medical image analysis. So most of our projects is related to medical image processing. And recently, our team have worked on generative AI for medical image analysis. So I think my topic is quite focused on this research area. Okay, so now let me talk about the generative AI for synthetic medical imaging. I apologize because I think because of my background, my presentation might be having a different flavor compared to other speakers. Hopefully it's not too technical, but if you have any questions, feel free to interrupt. And if you are interested in any models we developed, feel free to reach out after the presentation. Okay, so I think like the previous speakers already shared a lot about the AI. I think I can simply skip this, but one particular model I would like to point out is the generative adversarial network known as GAN model. So it was invented in 2014 by Ian Goodfellow, but people didn't realize its impact until I think maybe 2020. And now we know like this is the generative AI era. But before that, there are generative AI models available for medical for image analysis. And when we only have now we have multiple models available, generative AI tools. But when back in this time, when we only have GAN model, our team had already worked on using GAN in our research. So this is not a model we developed, but I would like to show it here because maybe people find it familiar. These hyper-realistic faces are actually generated by GAN model. And we are inspired by this work. And we think this is such a good, cool model. Are we able to use this in our research? And then we use GAN model in we decided to use the GAN model for two purposes in our research projects. The first one is GAN for data augmentation, and the second one is for stain imitation. I'll give more details about these two projects. That's please remember, like these projects are like 5 years ago, so it's no longer like a fancy anymore. But that's just a mark, the beginning of our research in using GAN model in our research. Okay, so GAN model or generative AI model in general can be used for different applications. And one specific application we'll look at is to increase the sample size. As we know, medical data is usually quite limited compared to generic images data sets. So this is in this study, we applied GAN model for data augmentation. So it's a similar process as generating the hyper-realistic faces, but we use it to generate hyper-realistic histopathology images, so that we may have more samples to train another model, for example, classification model for predicting molecular biomarker from histopathology images. Another issue it can use to address is to mitigate the imbalance distribution problem. And if this is unevenly distributed samples, then we can use GAN model or generative AI to increase the sample size of the majority class. So these are the two types of issues we addressed using GAN. And later, we also noticed that the GAN model is actually more powerful than that. So here is one example. Again, this is not a model developed by us, but I would show you here. It's easier to help us to understand. So we know, like for the histopathology images, if they came from different lab, if they use processed by different pathologists or machines, they may look different. And this is known as the stain variation. And it's okay if for trained pathologists to tell they are trained to ignore such variation and still can make accurate prediction diagnosis. But if we provide such images to train an AI model, then the AI model probably will get confused. It will be a barrier to improving the performance of AI model. So inspired by this work, it's a model developed by a German team, and they trained a GAN model so that it can change the artistic style of a painting. So it can be Van Gogh, it can be Picasso. And this is super cool. So we think, okay, are we able to develop a model to to reduce or normalize the skin colors among different datasets? And then that's what we did. So we trained a model, and it works fine. It can reduce the color variance among the different datasets. And this paper was published in Medical Image Analysis back in, I think, 2022. Yeah. But these are the old works, projects. I would like to showcase a few more recent projects we're working on. So the first one is how we use generative AI to generate synthetic MRI. And why this is important, because we know for MRI, there are many different sequences. Some are more advanced, some are routinely used. And one specific is known as the T1 gadolinium-enhanced MRI. So this will require injection of the gadolinium, the tracer or the contrast agents into the body. And some patients are allergic to this gadolinium contrast agent. And for patients, there are benefits if we are able to use generative AI to generate, the contrast MRI from non-contrast MRI. For patients, it can avoid the use of contrast agent injection and minimize scan time. And for hospital, can reduce, the reliance on the costly contrast agents and improve the efficiency of using the MRI scans. And our first approach is, again, using GAN model, and we developed a model. We use the non-contrast image as input, and then we use the GAN model to generate the T1 enhanced MRI. And a typical GAN model, there are two parts. One is called generator, the other is called discriminator. And these two modules compete with each other until the discriminator can no longer differentiate if the generated, if it can tell the difference between the fake or the real images, and the fake image is actually generated by the generator. This is how it works. And it shows like it works very well and in this study. And we clearly demonstrate, like compared to other generative AI model back then, our approach works better. It can clearly highlight the enhanced area in the T1 enhanced MRI. So this is quite important to make accurate diagnosis, especially related to the malignancy of the brain tumors. And further, we think, are we able to do better than that? So we developed another model. So instead of just because the previous model require we have the full non-contrast MRI sequences, but this is not usually available depending on the practice in different hospitals. Then we think if some patients, they only have one or two sequences available, not the full list of non-contrast MRI available, are we still able to accurately generate the T1 enhanced MRI? So we developed a model. This time we used the diffusion model. This is the latest generative AI model for image generation. And this specifically tackled the problem of the missing modality. And this paper was just recently accepted to MICHI 25, which is one of the top conferences in medical image computing. I'm going to ignore the technical details, but in short, these diffusion model-based generative model that works fine. And clearly it shows like even with missing modalities, it can still robustly generate the reliable and realistic T1 enhanced images. On top of that, we also test a different dataset. We used the diffusion model to generate diffusion weighted MRI. This is another advanced MRI sequence. And again, it shows like the performance is really great. So the second project I would like to showcase is we use generative AI for synthetic PET image generation. So PET is another imaging technology. So it requires induce the radio tracer into the body, and the radio tracer can be combined with specific molecules in body, so that when the body consumes these molecules, and in the same time it consumes the radio tracer, so that we are able to capture the, for example, abnormal metabolism, or like the abnormal activities, for example, within the brain. One example is in Alzheimer's disease. We may see the degenerative area that consume less energy compared to other normal brain areas. So if we use PET, it can clearly show like this kind of degeneration in the brain. And for tumor, it's the other way around. So usually the tumor will consume high energy. So the PET will show, the hyper intense area in the image. And because again, this require, it's the same as advanced MRI, require injection of a radio tracer, and it's quite costly. In Australia, it's not covered by Medicare, so this is a challenge. That's why we are motivated to use GAN model to generate PET from MRI, more accessible imaging modalities. Okay, so we developed a model. Again, we first used GAN for this project, and this paper was published in Neuro-Oncology Advances earlier this year. And this is what we did. So we have the MRI dataset, and we have a paired PET dataset, so that this gives us the dataset to train a generative AI, so that we can use MRI to generate PET. And in this study, we focused on FED PET, which is like a specific radio tracer can be attached to tumor cells. So this is quite unique to brain tumor applications. Okay, and then in this study, we use MRI to generate PET, but in the same time, we also analyze MRI alone. And we'd like to tell if from the MRI, we are able to tell if this is like malignant or a benign tumor. Usually these can only be confirmed from PET, but in the case of not having a PET, are we still able to do the job? And the answer is yes. And we found like in about like 85% of cases, the synthetic PET can offer clinical valuable information. And based on the analysis of the MRI and the synthetic PET, we probably can our classifier can achieve about 80% accuracy in predicting the high FET uptake. This is actually an indicator of the malignancy of the tumor. Or it's just like a few examples showing the generated PET image compared to the ground truth, the real PET image. And it works well on most of the cases, but clearly, as you can see in the last row here, if we see there is a hyperintense area in the PET, in the real image, but the synthetic image wouldn't be able to tell. So that means still this is not like quite, it's still far from a clinical use. And then later we think if we're able to, thank you very much. So we think if we are able to further extend this study, so that we again use the diffusion model instead, and to see if can improve the performance. And this time we also looking at multiple multiple PET tracers. So we tested like 4 PET tracers rather than just one in the previous study. And again, it demonstrated the diffusion model works better than the GAN model, at least in our study. And this paper, again, was accepted to the recent ESB conference 2025. Okay, the last project I would like to quickly go through is partly the generative that can used for neural imaging, but can also used for histopathoid images. One specific use case is the multiplex immunofluorescence images. This is actually a very advanced imaging technique. Actually, it's the stain technique, so that it can stain the same tissue slide with multiple stains. And that's how, when we put them together, it shows the colorful image here. But the problem of these stain technique is that it has high failure rate because it requires multiple stains. It's more complicated. And the reagent is also costly and requires specialized equipment. So we think, okay, if we just have a small panel of stains or biomarkers, are we able to imputate or generate the other biomarkers accurately? That's what we did, and we have 2 models developed. Just again, this is still in progress. We have tried the GAN model, the masked autoencoder model, and the diffusion model. And we also tried the different combinations of different generative models. And the latest model we have tried see is here. So this is actually a combination of different generative models, and it provides the best results so far. When we look at the image quality metrics like similarity in structural similarity index and PSNR, these metrics, it's substantially improved on the stain imputation performance. Okay, so that's just a quick showcase of our projects. Thank you very much for your attention. Well, if you are interested in any of these models or our research projects, feel free to reach out. Thank you.
Thanks for that presentation. You are obviously leading a lot of work there in Macquarie. I'm just going to look if we've got any questions. Yes, we've got one. Good research done by you and your team. What are the audit checks in place to prevent any AI technology, i.e. images developed by AI, are not misused by private medical hospitals or labs for claiming health insurance and cause financial stress on low economic populations in Australia?
I guess this is a fantastic question, but I have to say, I don't think I'm in a good position to answer this question. Well, I mean, our institute, we do have many researchers. They are working on, improving the safety, transparency, and equality of healthcare, and AI. It's just like a part of it. And in our counter research projects, mainly, clinical medicine research projects is still far away from, the real use of AI, or it's not quite ready yet. I'm not sure. I don't quite know. No.
Okay. I have a question around, for clinicians that are not involved in the project, have you presented these synthetic images? And if they do, what's been their reaction? Do they trust them as much as a traditional image?
That's right. So one common question we usually ask is, when you develop model, you generate synthetic images. So how are you going to demonstrate it can, of the same use or replace, the real images? So that's why in every project we're working on, we engage with the clinicians. I can give you one example. In this histopathology image generation project, we actually have pathologists reviewing the generated images for us. And the MRI is the same. So we have radiologists review the MRI, and they compare they are blindly, reviewing the images. They don't know if this is real or synthetic. And then they are asked to make decisions based on the image presented to them. And in our study, we found that the AI is really, has advanced to a stage. It's really hard for them to tell what is real, what is the fake. And in terms of the diagnostic tasks that they're performing, and it actually can achieve almost the same level of accuracy in specific diagnostic tasks, but not all of them. For the MRI, could be easier because it captures the global snapshot of the brain, for example. But for histopathology images, because it's down to the cellular level, so it may be more difficult to make a diagnosis for them.
Okay, thank you. Do we have any other questions, Patrick?
No, that seems to be it.
Okay, I've got a more general question, related to us in public health. Could synthetic data generation by AI help us address issues such as rare disease modeling or population subgroup analysis?
I actually think this might be like a potential solution. Actually, like in our study, we always deal with the small sample size and rare diseases. Like there's a specific cancer we're looking at the moment. I think it's called mesothelioma. And in our data, we would have about like 400 patients. Compared to brain tumor, thousands of patients' data, this is relatively small. But if you look at the histopathology images and all the structure of the cellular structures, so we have seen like path foundation models trained on large-scale histopathology images. And when we only use a small sample size from a specific rare disease, you can still, just use some advanced learning technique like zero-shot learning and few-shot learning can still perform really well. So I think maybe the solution is not quite straightforward using synthetic AI, but maybe use the pre-trained foundation model, like GPT is one example. It might work. It might be potentially a solution.
Okay, thank you for that answer. Barry?
Are you thinking, David, that Stats New Zealand should use AI for the next census?
Maybe they might have been exploring that idea. Okay, we shall move. Thank you, Sidong. Can I ask you also to stay behind for the end of the session for our discussion,
Sure.
please?
Thank you very much.
Thank you again for your presentation. I will move on to our last speaker for the day, who is Rooshan Ghous. She's the coordinator for the Centre for Research Excellence and Postgraduate Programme at Whitecliffe Education Limited. Her research interests lie in the development of responsible AI-based solutions for healthcare using multidisciplinary approaches. Welcome, Rooshan.
Sure, thank you and good afternoon. I'll just share my slides. Is it visible?
Yep.
Yes.
Thank you so much. So today I'll be presenting part of our study that we conducted last year. The study was basically trying to build a survival prediction model for women diagnosed with breast cancer in New Zealand. And we did use Explainable AI to make sure what we were trying to develop was making sense to our clinical advisors on board. I mean, we had their feedback looking at the model continuously as we developed it. During our study, we came across an unexpected finding, and which was the role of presence of DCIS within the invasive lesion on breast cancer prognosis, and that's what I'll be sharing today. So DCIS, as you know, is a non-aggressive cancer and considered stage 0 and is considered non-life threatening as long as it retains within the cell walls, within the cell walls. It remains non-invasive by itself, but its value when accompanied with the invasive lesion is less explored. There is some literature, but it's quite sparse and not consistent on the value of DCIS when it's present within or along with invasive lesion. So when we got our data, we received our data from Breast Cancer Foundation National Register, which has an incredible data resource. We requested 250 plus fields, which we then later narrowed down to about 26 used for building our model. Among those fields was one feature called diagnosis type. So diagnosis type is basically a binary feature that Breast Cancer Foundation collects, where 0 means a patient which has a purely invasive lesion, and 1 means a patient who has DCIS accompanied with their invasive lesion. So in our study, we found that diagnosis type, which is the field name, came across as one of the most significant feature that influences survival outcomes, especially for long-term survival. So here I'll just discuss some tests that we used, some explainable AI tests that we used to see why among all those features, diagnosis type came across as so important. So these are results from Chaplin analysis. It is one of the most trusted explainable AI algorithms used in healthcare. And these are 3 results from 5-year survival. The second is from 10-year, and the third is from 15-year survival. And here Shapley has ranked features according to their significance on survival outcome. The unique thing about SHAP analysis is that it's based on game theory in a way that each feature is separately viewed for its significance on the outcome. So it doesn't look at the entire model or all the set of features we feed in together and see what prediction it makes. Rather, it takes one feature, sees how important it is for the outcome, and then the second, and then the third, and then it ranks them according to their value. And here, if we see in the very first output, diagnosis type was 4th most important feature in survival and outcome for the patients. In the 10-year survival, it went up in its significance, coming just next to age group in its significance, and similarly it retains its second place in the 15-year survival, which is quite unusual because the nodal stage, the spread of cancer to the nodes, the size of the tumor, even ethnicity, or the invasive nature of the tumor, like type of tumor, histological type of tumor, all of them ranked lower than diagnosis type in long-term survival. So we did a few other tests to see how they performed, how they viewed this finding. This is just basically a similar test using SHAP, but here we can see how much a feature contributes to the outcome. And this is for 15-year survival, and we can see that age group clearly contributed the most, followed by diagnosis type, and then the others. But it does show that diagnosis type had much greater significance than the ones we would normally expect on the survival. Here we have got partial dependence plot, a very simple explainable tool that we use. It doesn't look at different features at one point in time. It just takes one feature and then sees its outcome, but it can see, it evaluates the categories within a feature. So here, as we know that 0 was patient who have purely invasive lesion, and sorry. So on y-axis, we have chances of survival. The outcome, the higher the value goes, the better chances a patient has of survival. And clearly the patients with DCIS component showed much better survival. And this plot, when viewed across 5, 10, and 15-year brackets, the difference got steeper in its value. We also wanted to see if there was any other feature interacting with the diagnosis type that was causing the result. So we just looked at a heat map. Sorry about the tiny text, but I would just share that diagnosis type is number 2 on both X and Y axis. And it has all the features, including treatment, demographic, and clinical pathological ones. And the heat map did not show any interaction of diagnosis type with those features. I'll move to the next slide. Here we took out the treatment features just to have a more clear picture to share. And here diagnosis type is number 1, and it can be seen it's not correlated with any other feature except with, this is 15-year survival. We just put it in the heat map to see how it's interacting. So the only feature it does interact with positively is the 15-year survival status, but nothing else. So this is kind of a reassurance that our finding that DCIS is independently causing some effect on survival time, a positive impact on survival time is valid. This is LIME, another commonly used tool of explainable AI tool. Here, orange color is for patients who it's not actually survived, but orange means having a higher chance of survival, and blue means having a low chance of survival. And the value in this diagram means the category assigned to a certain feature. For example, here ethnicity is 1 was for European patients. LIME is looking at one particular patient at one point in time. So it's not all the patients we took, not the whole cohort, but just one patient at a particular point in time. So this patient was European, and which we know from 1, which was the category assigned to it. And it's orange, which means they have a better chance of survival compared to others. Here again, and if you look at size bin, 1 was the smallest bin available. So this patient has a small tumor. And then again, it's orange, showing that smaller size was associated with better outcomes. And finally, our feature of interest diagnosis type is 0, which means they had a purely invasive lesion, and it's blue. Means just because they have that feature of purely invasive lesion, it appears it will have less chance of long-term survival. Sorry. So yeah, LIME just looks at one patient at a point in time, which is important. So we know that a few patients or a certain group is not skewing the results. So just a random patient shows the same results as rest of our model. Here we have Sharp scatter plot. It also gives really interesting and insightful insights into the model. So on x-axis we have diagnosis type, and on y-axis we have survival. So as the y-axis increases, the chances of survival are better. and 0 as are patients with purely invasive lesion, red are patient, 1 are patients with DCIS, invasive lesion. And we can see that patients who have purely invasive have a compact outcome. It doesn't have a broad range, and it is poorer as compared to patients who have a DCIS component. It's scattered, so they have a wide range of outcome. However, it is the whole wide range is better than those who had a purely invasive lesion. This is another plot that we saw these interaction for all the features, but this is just one of the interesting one that I'm sharing here. So this is called SHAP interaction plot. In this plot, you don't look at a single feature, but you select a single feature and try to view its interaction with another feature that you want to observe and any other important feature, and their combined result on the survival. So on x-axis, we have diagnosis type, and in interaction plot, the color of the scatter shows the second feature. So here our second feature is size of tumor, and as the color changes, so does the size. So dark blue means a very small tumor size, and then light blue means slightly bigger, and then pink and red would mean like largest tumor size. So here we can see again the patients who had purely invasive lesions and those who had a bigger tumor size. As you can see, the red ones are really bunched up on the bottom, had the worst outcomes as compared to patients with DCIS, which again had a wider range. And within that wider range, you can see now the size of the tumor, the red scatter dots, they're quite wide in their range. They're not bunched up on the bottom. So it just appears that even size of tumor is more influential when it is more influential when it's accompanied with invasive lesion. When it is with a lesion with DCIS, it has a more diluted effect. As you can see, it has a wider range now. It's just something we saw for all the features to understand how they were interacting with each other and influencing the survival. So yeah, a very brief presentation from me, and it was just to share the value of AI in understanding complex patterns that lie within data, especially cancer data. So we had multi-dimensional data and had many features to it: treatment, demographics, clinical, histopathology. And among all those, we were able to find that one particular feature that we were not even aware had this much significance was more influential than any other in our data. It definitely needs more work to ascertain if it is causal or not. But using all the AI-based tools, the well-known tools, we came to the same conclusion. No matter, we had 3 cohorts of patients. Sorry, I forgot to share, from 2002 to 2017. We divided our patients into 3 different cohorts. We followed them over different time periods of 5, 10, and 15 years. And no matter which cohort we took, the earlier ones in time or the later ones, or the ones with longer duration of survival analysis or shorter, we saw DCIS, presence of DCIS in the invasive lesion remains pretty critical, and we use different algorithms that we have. So behind SHAP, there are different algorithms that you could use in partial dependence plots and all those. So that remained consistent. And when we discussed with our clinical advisors, who are also our researchers, Dr. Vanessa and Ruben, they both agreed it could be a reason that DCIS has a certain pathogenesis, which is different from purely invasive lesion that could be causing this effect. They are less aggressive. A purely DCIS lesion is less aggressive from the onset. And if it is the case that it does develop into an invasive lesion, possibly carries that carcinogenic what should I say, ability or carcinogenic pathway. It follows its own pathway, which is less aggressive. It carries less mutations, and therefore it has better survival. So yeah, and I've got some literature review that backs up our study. There was very sparse literature on this topic and not consistent over time, but these are some of the papers if anyone would like to refer to. Yeah, finally, I would like to acknowledge Breast Cancer Foundation National Register for providing us with the data and their continued support through the project. To our Maori cultural advisor and Dr. Barry Gorman for continuously supporting us on the epidemiologic perspective for our study design. Thank you so much. I'm happy to take any questions.
Thank you, Rooshan. Very interesting presentation, and the way you came to your result and your unexpected finding. Do we have, just looking, do we have any questions? Not at the minute. So in the context of this, in the context of you using AI for this project, what would you describe were the limitations? Was it in terms of data quality, representativeness, or any potential bias?
I think the biggest limitation for us was not having enough time. Your data quality, the data is amazing. I genuinely believe we have one of the best data sources in the world. That's all the researchers that we have worked with have agreed, but it wasn't prepared for machine learning. I think our study was the first, and then there was another one to use AI on breast cancer data in New Zealand. We did struggle a lot to get this data. And yeah, so it wasn't prepared. So I think 90% of our time went into just cleaning the data and preparing for machine learning. So the biggest limitation was not having enough time. We would have loved to have more time to go deeper into the study, and not, although we did have a multidisciplinary team, we were very fortunate to have our oncologists, epidemiologists, our breast surgeon, and data scientists, but we didn't have a, for example, histopathologist, which was very critical for us because to clean and prepare the data, you need to bin it. Usually when you get data from SEER or from any other resource like in UK, it's already clean and prepared. So a lot of histopathologists or clinicians have worked on it and put it into nice tidy bins, and then you go on from there. We didn't have that. Our data was raw. So we would have definitely loved more input from clinicians, from histopathologists on how to handle the data. For example, type of data. I mean, there are, I think the register collects 15 plus types of cancers, and each patient can have multiple multiple types within their tumor. So when we prepared the data, there were around 70, 80 or more categories of lesions, which is immense. So just to put them into clean bins was a huge task. We went back and forth to literature, to clinicians, to just understand, because there's no standard guideline how you classify the histotype of patient of breast cancer. So that type of thing, I think still too much work needs to be done, and multidisciplinary, yeah, definitely input is needed to have more reliable data analysis.
So is that your next steps to, anticipate like a prospective validation of the findings?
Yes, yes, I believe. I mean, the tools are great, and that AI provides and everything. I think the most critical thing is having more people involved who have experience in each and every field that we need to handle, because we still don't have a standardized format, so it can be validated. Our techniques can be validated even further.
Thank you. We've got one question from our audience. Do you think your studies can increase in detection of type of cancer earlier than that in New Zealand? Is it useful in rural areas, for example?
Yes, certainly. So it's not part of this project, but I was very fortunate to discuss this with Dr. Berry, who's here, and we did discuss a more significant project could be possibly detecting the risk of cancer earlier before the screening age. So the screening age is 45, and mostly in like all the developed countries, GP clinics have a tool in which you can input the data and check whether that patient has a high risk of developing cancer. We do have a tool, but it's not built on our population and it's very basic. So it's not that targeted. So we need to build a tool on our own population that prompts the GP, okay, this patient has a very high risk of developing breast cancer, so they should be sent for screening before they turn 45. Because the most aggressive cancer, of course, are early age cancers, and it's just critical, and they are often asymptomatic. For example, lobular cancer, it's usually asymptomatic. It's not even picked up in screening because it's flat. The cells grow flat, not as a solid tumor. So for those type of cancers, having those tools have really internationally showed great value. So just using our delta to build a tool to detect the risk of developing cancer would bring incredible value, and those would be used in GP clinics pre-screening.
Thank you, Rooshan. I think we've come to the end of our time. So once again, really appreciate your time and your presentation this afternoon. If you could hang on with us for our discussion. We've now, I'd like to thank all our presenters for their insightful and thought-provoking talks. We've now arrived at the discussion part of our session, and as we have all our presenters present, I've thought we'd have a bit of a Q&A. So I encourage you guys listening to us to contribute to the Korero, and we'll start off with Barry.
Thanks, David, and once again, thanks to all the presenters. There's no doubt AI has a tremendous advantage in the health system. I think we all agree that with him. What's the disadvantages? Why wouldn't you want to use it?
Can I get Pedro to start with that question?
Yeah, look, I think that is a really good question, Barry, and it's one of those that, I mean, a lot of times in technology, and I will park for a second, artificial intelligence, right? Around technology, we start to use it just because it's a new trend and there's a hype around starting to use it, right? So I always start with the point, artificial intelligence doesn't solve all problems, solves a lot of really, really great problems, like the ones we have heard today, but it doesn't solve all the problems. A lot of times, other technologies and other advancements could help and be faster and more reliable and have more maturity. So I think a big disadvantage is using AI just for the sake of the hype over using AI right now, because obviously there is a push to use it from a commercial point of view, right? So I think it's when we as practitioners and leads in this area have to be quite upfront on the conversation that not AI and all types of AI is very important. We always think AI and people start talking right away specific types of AI. It's not, there's AI has been for a long time around. So I think that the answer to your question is the disadvantage is that you start using artificial intelligence because of the hype and the willingness to use it, the new technology, without really understanding the problem. And if there are other sources of technology that actually could benefit and solve the problem in a faster and more reliable way, because of basically you have more guardrails understanding and the technology is just more mature. So that's my comment on that one.
CK, do you have any
I think
in that area?
I think I can add my 2 cents to this. I think the biggest disadvantage or risk is mainly just the accuracy of these AI tools. End of the day, it is an algorithm that is just generating probability. You come in and choose a threshold to say this is positive, negative, or you use it as a decision aid. But there's built-in inaccuracies with any of these algorithms. So if you don't have a good understanding of where the inaccuracies lies, how is it going to be actually put into clinical practice? Because looking at kind of just accuracy measures isn't the whole thing. Once you do put it into clinical practice, how does that impact the entire workflow? And does it actually truly improve patient outcomes? I think those are still questions that we still need to answer as we implement AI into the healthcare systems, and those questions will need to be addressed.
Thanks, DK.
Excuse me, a discussion point from my anonymous friend in the chat who asks, AI technology and its information use is acceptable by New Zealand legal systems as it is not as it is not a legislative requirement. Not entirely sure if I understood that question. So anonymous attendee, if you'd like to throw up your hand, then you can actually contribute to this discussion directly yourself.
There are privacy and health practitioner codes that we do need to apply in the context of AI. Even though there's no specific AI regulations, there are other regulations that would apply into the AI context. So I'm not sure if you can say that there's no legislation in this AI space. There are. You just kind of have to find them and know where what legislations will apply into your use cases.
Thank you, CK. I've got a question for all the panel. What do you think is not getting enough attention in our current AI health landscape?
Anything that's not generative AI. So I think a lot of the kind of computer vision tools, they don't really get a lot of mention, but I think that's where the greatest value is going to lie. A lot of the generative AI use cases, there's still a lot of hype in it without any real clear evidence to say that there's kind of good impact. So yes, I think that's kind of not following the hype, follow the evidence.
Rooshan, do you have a comment around that?
I agree with others. Yeah, just I think having responsible AI would be best way to go. It's just we are in time of adaptation. Yeah, the more responsibly we go towards that step, that would be great. Yeah, it's inevitable. It's here, but yeah, responsible adaptation would be best way.
Thank you.
David, I got a question. The more I hear of these, more presentations I hear about AI, there's one couple of words, one term that never crops up is chat GPT. And yet for most people, that's chat GPT is AI. But for you people that are working with it, that's not a term that you use at all. Any comment?
I see you laughing, CK. Do you have a comment on that?
I was going to let others kind of chip in first, but I think the main thing from Health New Zealand's perspective is just ChatGPT is going to store, like, all your chat history gets retained. So there's massive privacy risk if you do end up using it for patient information. So I think there's probably happening anyway, but I think it's that issue of, yes, things like ChatGPT will be useful in certain situations, but I think there's a lack of understanding of when is it safe, when is it not. I think that messaging or that piece of education still needs to go through the healthcare system.
Thanks, CK. We've got a question from Carolyn. How do you all account for the environmental impact of AI use? We are meant to be decarbonising, including health, which I'm sure you are aware is already massively intense. Do you estimate changes in emissions in new AI interventions compared to old ways of doing business? Or are you just ignoring this impact currently? Who wants to go first on that? How about you, Pedro?
I think there are two topics, right? The first one is, I mean, if you look at the public service artificial intelligence framework, one of the key pillars is sustainability, right? I mean, of our principles. So I would say that is fundamental part of the way we deploy artificial intelligence in the public service. I think definitely there is a big piece of work led by the Minister of Business Innovation and Employment currently around looking at renewable energy to basically support the energy that you will need to be able to run this. Now, I think that it's a wider conversation, right? I mean, that's my first part of the context, right? To the answer to, so there's the question to say, are we ignoring it? No, it's cornerstone part at the framework, right? It's at the highest level that it could be, which is at the framework principles level. The second part is there is definitely a big piece of work in renewable energy in terms of New Zealand and how are we going to be catering for that into the future. After saying that, I mean, that is a challenge that we are all facing around the world, right? When we think about hyperscale and the compute power that we need in the back and where the resources are coming from, and how are we as a global citizen will be able to really move forward. I mean, most of the compute that we are currently consuming is not based in New Zealand. I mean, not from a GPU point of view, right? I mean, it's not in New Zealand, and it's consumed somewhere else, right? So I think it's just a global challenge we do have, that is a tension between the compute that is needed to really, the energy that is needed for a GPU and high scale GPUs to be able to process what we're after as a society versus the tension, obviously, emissions and renewable energy and where we are at. So I would say not ignoring it, but definitely a very important challenge that we're grappling as global citizens around the world. How do we solve it, and where's the trade-offs, and where's sort of the equilibrium part? And I mean, technology should be able to continue helping us as it has been doing, but it's definitely, we're not there, right? Still, like, we still burn fuel to deploy, GPU capacity.
Thanks for responding to that, Pedro. Sidong, do you have any comment? I realize I haven't brought you into the conversation, so apologies. Do you have any comments in
No
this?
worries at all. Yes. So I guess, like, within our institute, we have actually a climate change research stream, and this is actually what they are looking at the moment. The carbonization and decarbonization. And I guess, like, I'm not quite 100% can represent like what their their perspective, but I guess what we can see is at the moment this is definitely a big global challenge, and well, there are multiple ways, as Pedro just mentioned, like what about like just plant more trees? What about like you use like a clean energy for the GPU? What about like you have this actually I think people are really taking actions on it. One thing my observation is that at the moment probably have seen like the computer resources or the AI innovation is mostly driven by these giant tech companies like Facebook, Google, and they have the resources to develop so-called the foundation models. I think like ChatGPT is one of them. And the thing is, like, if they spend a lot of money, effort, and taking a lot of resources to develop such models, do we have to like create other big models, and these just to replicate in this kind of arsenal, wrestling or competition, that could be a possible waste. But on the other hand, if we consider these foundation models like ChatGPT as infrastructure, once the infrastructure is built, then when people start to use it, and then there are other approaches to use it. For example, if we use edge AI devices, this is low cost efficient AI. It just interact with the infrastructure, the big models. Probably that's a more efficient way. and a more energy saving way to get through this. And another thing I would like to respond to, just as Barry asked. So I think to most of people, ChatGPT is AI. Yes, it is. Of course, it is. I guess maybe like many people don't realize they are interacting with AI on a daily basis. Why ChatGPT is so popular and people think this is kind of the only AI? Maybe because they make it like a tool. GPT exists for a couple of years before ChatGPT becomes available, and only because it has this allows this interaction between AI model and user, and then people start realize, okay, this is how we can use AI and how they kind of get to know what AI is. But apparently there are many other models maybe people are not quite aware of. In our projects, as we mentioned, we have many other generative models we used that apparently not kind of have been converted into a tool like a GPT, still like a step away from it. Thank you.
Thank you, Sidong. We've got another question in the Q&A. In the Aotearoa context, how are we ensuring that any potential AI applications consider and ensure that Māori data sovereignty principles are upheld? Can I ask you, Pedro, to come in on this one?
Yeah, look, I think that there's two parts to feel like every question I have to answer, I go for two parts, right? But I think the first one is, and I keep on saying this one because artificial intelligence is the technology that we have at the front, right? But we don't create frameworks for every technology, right? We create frameworks that are at the highest level of principles, and these adapt and these apply here. We already have clear guardrails and frameworks, and basically have been, Stats New Zealand as the data stewards for the government have provided clear guidance in this space, and they will apply also to artificial intelligence. It will not be different. However, as I mentioned before, the way we are doing it, we are developing a specific artificial intelligence Maori perspective, which data sovereignty is part of that Maori perspective in terms of that specific principle, to develop a kind of below the line toolkit that will help our practitioners to ensure the controls and the thinking are part of the journey and they are not a separate thing. So the short answer is we are continue using what we have already been guided by the New Zealand Government Chief Data Steward that sits in Stats New Zealand, continue using those guidelines. And we are also developing a specific toolkit for artificial intelligence. So that is the way we are doing it. And yeah, happy to deep dive into any of those artifacts or more detail if needed.
So in terms of how you developed your framework, and you mentioned the data iwi leaders, how involved have they been in developing the framework?
Completely involved. We have a minority agreement, which sits at that mana-to-mana agreement at the chief executive level, at the highest level, that's a GCDO, and work collaboratively across all our program of work. So, it's not I give you a task, it's a true partnership, mana-to-mana agreement.
Okay, thanks. CK, do you have any comments in that area around data sovereignty and the considerations that Health New Zealand have in AI technology in the health sector?
Yeah, so I think like within Health New Zealand, we do have this group called National AI and Algorithm Expert Advisory Group. They've been around for around 5 years, just trying to provide some form of governance to AI initiatives, initially in Auckland, Waikato, but now more at national scale. So the framework that we do use within that group, it is it consists of 8-9 different domains. One of the domains that we do look at is around Māori involvement or kind of the equity considerations as well as data sovereignty. So we do ask all groups who are either trying to develop or implement AI to engage with Māori, make sure that they've considered these principles, make sure the data doesn't get sent off overseas, make sure it doesn't get used for secondary purposes without consent, make sure that you've checked for bias. So we do look for all those things when we either endorse or start to develop kind of different AI tools. One easy good example, just AI scribe around how well do those tools actually understand Te Reo Māori? Are they able to account for the different language or different accents? So it's those sort of considerations, even though it could be a bit basic, needs to be considered.
Thank you. I think we've got time for one more question. We are slightly over time, but this again is from an anonymous attendee. Good presentations and good information sharing. When we do not have good systems in place to report through other manners like BPAC, HS, DIRT, how can we depend on AI for more accurate information for reporting purposes as well as for our policy submissions? That's the first part of the system. So I guess that goes back to your data quality and how what you use to what you do then to ingest that data into your model. CK, do you have any? I see this is probably related to the health system more than anything, so I'll ask you again, CK.
Yeah, just struggling a little trying to understand this question. I guess if it's data related, data quality is always an issue, but I think as you have more electronic systems being introduced, that data quality should improve. Same with structured or a structured structured process for data entry. I think as we kind of have more electronic systems, the amount of data you'll capture, the quality should improve more and more. I guess I think the second part of that question is more around the administrative or non-clinical use case for AI. It is an area that we do look at. So things like Copilot, they are somewhat useful. Things like meeting minutes, we're in the process of trying to provide Gen AI access to Health New Zealand staff, mainly through Azure services, just so that you can have a web portal with a system prompt in the back end for a specific use case. I think that's kind of the approach that we are taking. Yeah, hopefully that answers the question.
Thank you, CK. I think we're at our time today, so I just want to again thank all of you presenters in the morning and this afternoon. I hope everyone has really enjoyed it. I certainly have. I think Patrick mentioned we have about representatives from 12 countries across the 3 days. So that's really good for us and really exciting to hear what's going on outside of the country. It's clear, as we've all said, that AI is no doubt going to impact all our lives in work and outside. So thank you again for attending today, and I will hand over to Tim for our Karakia whakamutanga.
He, David, and yep, just like to reflect that as well and share our appreciation for everyone attending and everyone doing their presentations. It's great. Mi karakia tātou, ki whakatau ti tapu, ki wātia a te ara, ki tā turuku whakatau e, ki tā turuku whakatau e, humi e, hui e, tai ki e.